is connected.
I'm not sure she picked that up.
You're there, Hannah? No. Oh, yes. Yeah. You're on mute, Hannah, but good morning.
Good morning.
Good to see you. The fact it's working. Apparently, we can't stream live at the moment, Hannah, so it's just you watching us from a distance.
Okie dokie.
So good morning, everybody. So we've got 3 apologies today. We've got Jogger and Peter, who is on holiday, and Kevin, who are not here. We've got Hannah, of course, on the screen. So that's all good. I don't think there's anything else. There's no point in saying my normal stuff about governance, because that's always directed to the external audience, and there is no external audience at the moment. So we'll let that go straight by. Any declarations of interest in relation to today's meeting? Nope. We've got the minutes of the previous meeting, which everybody's seen. Everybody content to approve those? Yes.
I want to say there's a typo at the top of the minutes. They've got the job titles mixed up between Estelle and myself.
Ooh. Okay.
I'm always interested in talented staff, Beth. There we are.
Maybe there's something better that you don't know about.
Maybe there is.
Perfect. Thank you. Other than that, everybody content? Good. There were 2 items on the action log. One regards the consultant closed targets, which I believe is going to be dealt with in a board development day in the summer. And the other was an action concerning the Welsh Audit Wales, which again, I believe has been dealt with. So if everybody's content with that, we can move on. In terms of chair reports, the only matters I want just to bear with people's attention, you'll know that Peter Cowan has obviously already joined us, although he's taken an early holiday. It's a good thing to do. Ian is about to join us. I've met with them both, and I know, Kerry, you've met with them both. And I mean, Peter has already chaired his first audit committee. And I think everybody's very, very pleased to have both of them here. So they're going to be good. But the sad thing, of course, is that Paul, it's your last meeting today. We'll speak more about that later. But I can't. Oh no, we've got plenty of time. But I can't believe it's here. I was saying to Trish earlier that we've kind of known this was going to happen. Yeah. And I mean, I can't believe this is your last meeting, and we're very sad that that is the case. However, it is, and we'll move on with the agenda. And so we'll go straight to Chief Executive report.
Okay, thanks, Jim. So as usual, I'll pull out 4 or 5 items from the report, and then happy to take any questions on it. So first of all, if I could just take you to the bottom of page 3, the last, the bottom of page 3, the last dot point in the summary of kind of key meetings that I've had. And this is that Angie and I supported the Senate's Equality and Social Justice Committee inquiry into culture in fire and rescue services in Wales week before last. We provided a written summary of evidence against the terms of reference for that committee's inquiry, detailing the work that we've been on, the journey that we've been on in the last 24 months, Angie, around our culture since the independent assessment we had about 2 years ago. And essentially what we're seeking to share with the committee is the journey we've been on, the interventions we've taken, the learning we've had about the approach that we've taken, recognising, of course, that we still have much more work to do. And of course, the results from the recent staff survey signal that to us as well. There's much in that that's good, but equally it also signals to us there's still work to do on safety in our workplaces for all of our people. But it was a good opportunity to share the approach that we've been taking, and we've offered some further evidence to the committee subsequent to that too. If I can then go to page 5 of the report, this details a long list. I'm deliberately drawing this out, a long list of estates activity which is underway. So I'm drawing it out firstly to recognise what the contribution and the effort that the relatively small team Chris has to the overall organisation, and for colleagues across the organisation, to recognise we've got work going on for a new site in Dogethly, in Ruthin, activity about replacement or upgrade to the Monmouth station. We've got work underway about Swansea. In Swansea, we've got work in Llangennau, in Newport, and in the North Wales CCC, and activity around decarbonisation in 5 sites as well. So there's a long list of activity that's underway. around the estate. And of course, that's on the back of recent projects which have been delivered, which include the new site in Merthyr for Fleet. So I think it's just important colleagues across the organisation, recognise the breadth of the work which is underway to improve the estate. If we then go to the top of page 7, the board will be familiar with the fact, obviously, that we are seeking to replace CAS, so that's the essentially the call handling system in the 111 service by the end of May. Progress with the implementation of the product which has been chosen, which appears at paragraph 26, so that's C3 from MIS, which mirrors the 999 call handling system and the clinical ECNS, the clinical assessment service in the clinical support desk. So those two products have been chosen. Implementation progresses well. Training has commenced. Procedures are being written, and we're on track. Still some risk in it, but on track for implementation prior to the end of the contract with the current supplier in May. So that's good news. And again, thanks, we've said this before, but thanks to the team that are involved in that, because they're working at pace, doing a piece of work that would normally be across 18 or 24 months in something like 6. So there's a lot of activity in a very short period of time, and the team are doing great work there. Next, if I can go to the top of page 13, this is paragraph 55. This touches on the mental health response vehicle pilot in Aneurin and Bevan. We're particularly pleased to get this off the ground, as it's something that we've been looking to do for a number of years now, essentially taking evidence from other ambulance services across the UK, particularly in England and particularly in the southwest, where there's been a good model running for a number of years. This pilot has been part funded by resources from the Regional Partnership Board. The pilot will come to a conclusion soon, but it's important for us in the context of a national project entitled Right Care, Right Person, which is going to see activity move from policing across to health. So this is about making sure that a mental health patient accesses the right care at the right time, and policing or enforcement of is often not the right access point for those patients. That is likely to lead to an increase in activity for us, and we'll return to that in our thinking and planning for the rest of the year about how we respond to that activity when it starts to come across. But this mental health response vehicle pilot will be a good precursor to that later in the year. There's 2 visits which the clinical team have undertaken, which appear at paragraph 69 and 77, which I just think is important to draw attention to. So we're looking across ambulance services around the UK for best practice and things that we can learn from and adopt. And the clinical team recently hosted a visit from South East Coast Ambulance Service, and we've also been to the London Ambulance Service in recent weeks, again looking at their model and seeing what we can learn and adapt here. And then the final point I just want to draw out, which connects, final point I want to draw out from the report, which connects to an announcement I'll talk about in a second, is a paragraph 78 and 79. This is about research and innovation, and this talks about the Paramedic 3 and the Rapid 2 projects and trials. It touches on the number of patients that have been recruited, the number of staff that have been retrained, and of course trained. Of course, this is a signal of our continuing commitment to research across the sector, an important part of what we do. And then finally, Chair, if I can, just before I open up for any questions, I'm pleased to be able to share with the board and announce today that from the 1st of April, we will become a university NHS trust. We'll be the second UK ambulance service to be a university NHS trust. This is an important commitment or signal of our commitment to the education and development of our people and research across the sector. The Cabinet Secretary for Health and Social Care has therefore bestowed the university badge on us, but of course it's more than a badge. It's about what we do and the journey we are on with education, with our partnerships with universities and with research. So thanks to the team that have been working behind the scenes on that, particularly the board committee, and also Nigel, who heads up our research department. So from the 1st of April, our legal name will change to the Welsh Ambulance Services University NHS Trust. And from the 2nd of April, we'll start to see our branding change with the new legal title and also the new crown badge, which will be bilingual for the first time. This is obviously in recognition of King Charles exceeding the throne and the change in the crown on the crown badge. So it'll be the first time we've had a bilingual crown badge, and that will start to be used from the 2nd of April too. So good news on that one. So I'm happy to stop, Chairman, and take any questions.
Okay, any questions to the Chief Executive? I've got a couple of, oh, sorry, go on then, Kerry. Yep.
Well, just one question actually, but before that, just a couple of observations. Firstly, congratulations on your
Thanks.
your medal, King's Ambulance, and also I think it's prudent to mention Nikki Harvey safeguarding, because I think I read in the report, is it 10 years, almost a decade of you know, being the safeguarding lead, and you know, I've seen others will have been more involved, but I've seen the excellent reports, and it's a complex area for us, so I just wanted to mention that. Also, I think the progress around our dementia work and showcasing that internationally really demonstrates the quality of that work. And my question was, I think, probably for Chris, but it was around point 22 on the All Wales Capital Programme and the work around priorities for 10 years. So when I was reading that, Chris, I was just thinking, you know, in the context of where we might be in 10 years' time and potentially a different model, I just wondered if you know, you or Jason could just share some thoughts on your approach to that.
Yes, very timely actually. We only talked about it as an executive team yesterday afternoon as well, in terms of how do you respond to that. So very quickly, it's been a request by government, building on something that was requested a little while ago about the outlook for 10 years from across all of the NHS in Wales, not just us. You know, we've been asked to contribute to that. To help inform us best from a government perspective the prioritisation of, you know, what is spent on an All Wales capital programme basis of somewhere in the region of about £300 to £400 million a year across the NHS in Wales. Now, we are actually in a fortunate position in terms of what we've been able to respond to that, in that we've already got a good part of our capital planning over that kind of period mapped out in our estate strategic plan and our fleet strategic plan, and more recently what we need to deliver as part of our decarbonisation action plan. So we have submitted. The deadline was next week, but we've submitted this week what's been required of us. There's nothing new in what we've submitted to that. There's not already been in some of those documents already, with a few additionalities that we're aware of at this time coming in. But you're absolutely right in the conversation we had yesterday that, you know, there's inevitably going to be much more granular detail in years 1, 2, 3 of that. Once you get beyond, you know, a year 3, you know, there are indications of what we currently have as a prioritised list of estate we need to improve and replace over that kind of time frame. What our fleet replacement programme starts to look like. But even just on that one, the fleet, you know, we know that we're probably going to rewrite our fleet strategy sometime over the next 12 months, so things will move. So it's a request that's coming to us, which we have responded to clearly in the best way that we can currently. What government and how government are going to now deal with that, because they're going to be seeing, you know, this. So we submitted, it's quite a detailed pro forma we've had to submit, up to about 8 to 10 pages of detail for 21 schemes we've submitted, and these are just ones that we will be putting business cases in for Wales Capital. So on top of that, we have our annual discretionary, we do a lot of our capital flow anyway. But you know, if we've put in that kind of volume, you know, 10, 12, 15 organisations across Wales, there's going to be a significant volume for government to deal with. But we will work closely with government colleagues over the next 6 months to ensure when our voice is heard in that prioritisation exercise that is ongoing. But as you say, how we need to ensure, and we have signalled where we can in it, that say for anything that's in that plan from say year 4 onwards, it's an indication at this stage. But by the time we get to it, it's subject to potentially be quite different. But it's just a tool to try and help government better understand the needs going forward. I guess in some consequences, context, lobby for more money to support it, because the ask will be greater than what the fund is available for, as we know. But then how collectively across the NHS Wales that gets prioritised.
Thank you, Chair. Thank you for your report, Jason. No questions from me because it's very clear. Just a few comments. There are so many positives in this report, and Kerry's drawn attention to 1 or 2, but I felt it prudent to draw attention to just 1 or 2 others. The first thing I wanted to mention was paragraphs 25 to 27, which is around CAS replacement. And we discussed this recently in one of the committee meetings, and I just wanted to acknowledge really all of the effort and hard work put in by the team involved in that, because it's been phenomenal, I think, to get us to the point that we're at so quickly, given the recent situation with Salah. So I just wanted to thank the team and put it on record. We recognise the significance of the work undertaken. Paragraph 42 then refers to the Welsh language and the work that we've been continuing to do there. And again, I note the recent meeting with the Welsh Language Commissioner, and also the fact that we've been commended on our work in terms of the Welsh language 111 call answering, but also the bilingual recruitment. And I know we've worked really hard on that for many months, so it's great to see that recognition, I suppose, and that come into fruition. And then finally, from myself then, the point that you made reference to, Jason, which is the mental health pilot in Iron Bev, and I think that's so exciting. And the statistics so far are compelling, aren't they? So 75% are treated at scene. This could have a huge impact. So very much looking forward to see how this continues to develop over the coming months, and hopefully it can expand further, because the need is definitely there and it's having the right impact. So thank you for that. Very well done to all involved.
Thanks, Pepper. Anybody else? I've got a couple of things. Commissioning, is it worth mentioning just new commissioning arrangements are almost upon us?
So they are.
Final details now seem to have emerged.
Yeah, so the new commissioning arrangements, the joint committee will take effect from the 1st of April. It's not an April Fool. Yes. And the interim chief commissioner has been confirmed as Abby Harris, who we moving across from Cardiff and Vale. She's been the director of strategy there for a number of years, but also a previous trust chief exec in Wales. So she'll be taking over the reins from the 1st of April. The ambulance commissioner will continue to be Stephen Harry, as we know, for the next 3 to 6 months. He will assume responsibility for 111 commissioning from essentially with effect from the 1st of April, but the 111 programme board will continue in shadow form for 3 months. So there's a transition period, if you like, that will go through. And the first meeting of the joint committee is already established in the diary for the back end of April, which we will be attending. So progress, still much to settle. But key appointments have been made. I understand there's an announcement imminent on the chair of the new joint committee too. And so those kind of tier 1 appointments are in place. There's an organisational change process which continues for those colleagues which work in the current WISC and ESC arrangements, and how they will transition across to the new committee. But we've got the key appointments, we've got the contacts in, and we will be at the first meeting of the committee.
And the biggest change for us, I guess, in many ways, is the 111, isn't it?
It is.
That we are genuinely, from the 1st of April, receiving a commissioning basis rather than a kind of reclaiming cost basis.
Yeah, so it's a good move forward for us that 111 will be commissioned and will be connected to. I think this is, think about our strategy in the future direction, bringing the commissioning of the 999 and the 111 service much closer together offers opportunity not only for more effective use of scarce public money resources in the NHS, but also better opportunity for access for patients too. So it's a good move.
Yeah. And in your paper, you talk about some changes to kind of career paths within the 111 call centre, I think, potentially.
Help me
Is
out,
that right?
please.
Did I not read that there are some potential changes to the career paths within the 111 call centre?
With EMS coordination.
Yeah.
So in 999
Nine as
centre
well.
rather than 111.
Oh, it's 9, not the ones.
Correct. Yes. So got me to.
No, that's fine. No, I was talking about the ones. That was okay. Okay, Grant. The other thing is that we're just mentioning, you can see your road shows coming up.
Yeah, they are.
For Ned, particularly to
Yeah.
have in the diary.
So an appeal to Ned colleagues to come along. Paul, clearly you're excused. You're very well.
Not necessarily.
You're very welcome. You can turn up. You're very welcome to turn up. So we've got the Spring Roadshow round starting on the 15th of April, Monday the 15th of April in North Wales. This again, actually starting again in North Wales, in Wrexham, and then across to Anglesey on the Monday, and then across Wales through the week. We're taking a slightly different approach this year to the format based on feedback from the last occasion. You know, we continue to develop the format, but we've been publicising the dates, the times, and the venues internally. We covered it in the WAST Live earlier this week, and we're looking forward to good attendance from colleagues. You know, we normally see 500 or 600 people face to face throughout those events, and we'll be talking actually importantly about content. I mean, we'll come to the IMTP later, but some of the detail in the IMTP this year, and the exciting point where we're now going to begin to make further iterations to our clinical response model, more of what we've already been doing, but enhancing the opportunities for clinical assessment to ensure we send the right response to the right patient first time. Yeah.
Okay. And the only other thing I was going to mention, I might just want to make a few mentions of, Jason, for Ned colleagues, having had a conversation with our TU colleagues the other day about fumes, and I know that you know, on the ramps, I know that you spent quite a bit of time on the WAST Live talking about fumes and talking about the lines and all that kind of stuff. But I know it's a particular point that Hugh and Damon both made to me that it's a very real issue. And I don't know whether you saw the WAST Live yesterday or the day before, but you know, there was mention of it there. But for Ned colleagues who've been to the ramps and have seen, you know, there is an issue. Clearly, with the better weather, the focus might diminish a bit, but that will be a shame because by the time we get to the winter, if we're not careful, we might be back to square one. So I just wanted to
I mean, I'll just say a few words on it. I mean, it's a good point, Colin. This is the issue of diesel fumes at emergency departments, which of course is a consequence of handover delays and the need during cold weather or hot weather to run heating or cooling for the saloon of the vehicle. Now, in confined areas or where we've got canopies at emergency departments, it is the case that those fumes are there, and it is an unpleasant experience for our people. There's no doubt about that. It is an unpleasant experience. Now, we have done a lot of environmental monitoring, and we're confident as a result of that environmental monitoring that is going to continue, actually. So it's not just a one-off, it's going to continue on a periodic basis. We're confident that we don't have any breaches of the relevant safety requirements in place. But that's not just to say, you know, we're going to sit on our hands and pretend there isn't a problem, because it is an unpleasant experience for our people. So we've been working with emergency departments, and actually I was only talking to colleagues in BCU in the north earlier this week about this very issue, about the provision of shoreline, so electrical supplies which our vehicles can plug into, because then we don't have to run the engines for the heating or cooling. So we have some shorelines in place, and we were talking to BCU colleagues about the provision of more in North Wales. Weren't we, back on the back of conversations we had? We've issued guidance to staff in January, and again at a recent WAST Live where we took everyone through a detailed presentation about some of the practical steps that our people can take to mitigate and limit the exposure to the fumes. So, only running the engines when we need to. We don't, if the shorelines are there, we don't need to run engines. If we do need to run engines because there aren't shorelines, make sure we do it away from a ramp, away from a canopy and all those kind of things. Keep the doors and windows closed of the vehicle. So there are practical steps our people can take to limit their exposure to the unpleasant fumes. We're continuing the environmental monitoring to make sure it's safe for our people, which the results tell us at the moment it is. And we're continuing to work with colleagues in health boards to get as many shorelines and other mitigations in place as we can. I don't know, Liam, you own this, from a director perspective. If there's anything else you want to say on that?
Only other thing which we've been in discussion with TUs on is there any more we can do internally with the vehicle in terms of supporting air filtration? So we've been working quite hard that the air filtration that's used effectively in the vehicles ensures that people are least exposed to the symptoms that kind of the nausea that some people feel on occasion. So using what we have already effectively is obviously the most important thing we can do now, but we are also working with a couple of industry partners to see if there's any further action that we could take on a longer term basis that would support. And we've had suggestions from the TUs based on other experiences internationally that we're exploring, as well as a direct partnership with a manufacturer at the moment that we're hoping to be able to progress.
Good. Okay, thanks. Are you okay? Do you want to add anything? I know we've talked about it, and it's very much a live issue. It's not going to go away. It's something which is definitely a focus of attention. And I think the important thing you mentioned, there's one thing on the basis that it may pass a legal test, but on the other hand, it doesn't pass the pleasant test, and it's something that we need to keep very much in our minds.
Thank you, Chair. Thank you, Jason, for that update. And it's encouraging to see that BCU are looking at additional shorelines. Having said that, the issue we've got is that the shorelines that are in place now, some of them are not working, and some of them haven't working since the date that they've been installed. We're having issues with who is responsible for the maintenance. So that needs further discussion. I'm guessing locally, the local team up north. Yes, it is very unpleasant sometimes, and we do need to possibly do more work at this as to how we can take away the fears of the staff.
Good. Okay, well, not good. You know what I mean? Okay, set an airing. I think it's a topic that we need to keep under our review. Okay, anything else to Chief Exec? Happy with that? Thank you very much. In that case, we'll move on. It is to note, which we duly do. Item number 7, questions from the public. I believe, Estelle, we don't actually have any today. Is that correct?
We don't at this stage, Chair, no.
Okay, that's good. The next item is staff story, but that is deferred until this afternoon for various reasons, so that's fine. So we move on to item 8, which is our progress against mitigations for avoidable harm. Our standard paper on hand delays, etc. So, Jason, I guess back to you.
Thanks, Colin. So the paper is before you, and I'll take it as read. Just draw out a couple of points here. And a strong connection to the conversation we'll have later about the IMTP and actions in the plan for this year, which will support or are designed to support further improvements in this area, particularly around patient experience, patient safety, and quality. So we'll probably return to that when we get to the IMTP discussion later. If we go to the graph at paragraph 4, this captures the current trend in handover lost hours. You can see, sadly, across recent months, there has been a rise in the totality of lost hours, almost to the peak that we saw 2 winters ago, or last winter, sorry, 2 winters ago. And it's fair to say that whilst overall, I think we would say that pressure across the system through this winter has been less than last year. There have been some quite extreme pinch points, both in terms of days, but also in terms of locations. So we continue to work with health board colleagues at a local level and also with Welsh Government on actions to eradicate particularly the very long waits, which takes me actually to the second set of graphs here halfway through page 4. where you can see the 4-hour trend. So you remember, board members will remember there's been a commitment to essentially eradicate any handover delay of 4 hours or more. You can see the trend there in the top graph on the national basis, but of course, where we know focused work has taken place, and this graph here talks about Cardiff and Vale, you can see that they've essentially been eradicated. We've got good progress in a couple of other sites. CTM would be one that's worth calling out. And I do think whilst there is variability across North Wales, we are starting to see some improvements in some sites there. And I was particularly pleased having actually visited North Wales earlier this week for 2 days to talk to staff, both on the ramps. Rachel, you and I spoke to colleagues on the ramp at Wrexham, and then I had an opportunity to talk about 30 or 40 staff in a development day on Tuesday in Wrexham. And what was clear from the anecdote and also from the data which the local management team shared with me is that there, whilst one or two of the 3 sites across North Wales continue to be really pressured, there is good practice particularly in one site where we've seen a reduction in lost hours. So there are signs, I think, that the things are starting to improve there too.
Can I just interrupt, just ask whether do you see some parallel behaviours going on there in parallel with what we've seen going on in Cardiff and what we heard from some of the English hospitals in terms of management focus and attention to it? Is that what's making the difference, or something different?
I think it's probably a bit too early to say, Colin, and that's obviously because there are significant challenges right across North Wales with BCU. But I think Rachel and I had a very positive and encouraging discussion with the chief executive of the health board on Monday, not only about the here and now and her plan for improvement in the here and now over the next 12 and 24 months, but also the future direction and strategy, which we'll return to a later point. So I do think there are encouraging signs coming through in North Wales. And perhaps the final point or two just to draw out from this paper is the top of page 6. This is red performance, and again, whilst the percentage of patients that we respond to within 8 minutes continues to be under the target, we do know that the raw number of patients that we are responding to with 8 minutes is higher than this time last year. So that trend continues. We're getting to more patients more quickly than we did before. And then finally, paragraph 15, you can see a series of dot points there which talk about further actions designed to mitigate and improve and reduce harm and improve the patient experience across the service. Many of those are planned in this year's IMTP. We can return to that later, Chair, if we want to, but there's just a list of those actions there, and happy to take any questions on it.
Okay, thanks, Jason. So any questions or comments to Jason on our 2 highest risks? Kerry?
I wanted to ask about the overall lost hours this winter. So I was at the Vice Chair's meeting, I think it was in December, and the Minister mentioned it was 40% reduction in lost hours in comparison to last year. And actually, congratulated the health board on that progress. So it's helpful, I think, for us to have that. So you've mentioned some statistics today, but I think it's helpful for us to have that, wider perspective, certainly helpful for me, because there are forums, that we may find ourselves in where it's helpful to have the wider context on it.
Yeah, I think I can see Lee rapidly trying to find the numbers, but I think it would be fair to say, and I'll stand corrected on this when he's got them all, I think it would be fair to say that we have seen quite a marked reduction in the totality of very long waits. Yeah. So I think it's fair to say we've seen quite a sharp reduction in the volume of very long waits. I wouldn't necessarily recognise a 40% reduction in the totality of hours across winter. I can see Lee agreeing.
Well, apologies, I didn't mean to put you on the spot, but I guess my point really around some of the numbers, and I think, Rachel, you and I had a conversation very quick conversation about this, and some of how we frame this might be helpful. So, you know, as we get towards the end of winter, some of those comparisons.
Yeah.
And without causing too much work, that context around health boards as well is helpful when we're going out and triangulating.
Okay, let's bring in Lee and Rachel, perhaps just on some of the detail there.
Yeah, thanks, Jason. I mean, what's very fair to reflect is December 23 was 10,000 hours less lost compared to December 22, which I think just highlights how difficult December 22 was. December 23 still at 23,000 hours is still far too high. So December was an improvement, and a 10,000 hours is not an insignificant improvement. Arguably degrees of poor. January and February, however, coming into this year are not favourable compared to 23, so they are worse. And February landing, as you know in the papers, we've got in the region of 24,000, comparing to just over 19,000 last year. So unfortunately, very much got in the wrong direction.
Rachel?
I mean, that was exactly what I was going to say. That I think it is a case that you can, depending on your audience, point to different stories depending on which month you look at, which quarter you look at, which year you look at, so I'd say that's why we use these longitudinal graphs, so that we can see a longer picture rather than snapshots, which can sometimes perhaps have a slightly different slant to them.
Sorry, could I just mention, it's just an observation just on the amber ones. I know we always talk about it, but in a recent visit, when I asked about amber ones, the response I got was, I think it's very rare that those amber ones are released. And I note from the figures, 308 declined in this period, 148 accepted. And as a board, I think we are cited on this at WAST, but it really concerns me. And of course, it links obviously to the handover delays. So I just wanted to make that point, Chair.
Yeah, before you come on then, Paul, do you want to make a comment about the amber, about the releases? Because it is very stark. The reds are good, but the amber releases are really very poor.
Yeah. I think what, and I'm trying to remember, I think what we need to do is just bring through a health board breakdown on that, because it's not fair for us to suggest it's a all of Wales issue. And I can say that from a point of reviewing these on a weekly basis. It is particularly concentrated, and there is a correlation with where the most number of hours are lost correlates to where there is a more challenging time in releasing ambulances on those immediate release requests. But it does happen across Wales, but there is significant variation, and I think somehow we perhaps just should bring that through to allow you to see that. Perhaps something for Finance and Performance Committee
I think you should, yes, because in terms of the learned helplessness, we get into a point where we keep going back over the same things, which is understandable. But this is something that we perhaps could just have a little bit of a focus on, and maybe something that we could do a bit of tweaking somewhere by some attention to.
I think also at Quest would be my preference, because of course it correlates directly then presumably to the work that Liam and the team are doing around harm. So if that's possible.
Yeah, no, of course. Yeah, okay, that's helpful. I think Paul wanted to come in and then talk about them.
I'm just going to pick up the SDEC again.
Yeah.
When is that going to be evaluated across the system, rather? Because we can see that we're not having access to it, and I just wonder, it's a significant investment in health board, and I just wonder what the effectiveness is generally for SDECs. Is it something that the health boards are actually using and it's making a difference, although they're not allowing us access to it?
So there's been a series of workshops.
I suppose I'm frustrated in seeing the same thing every
There's a club for it, Paul. You're welcome to join.
It's just
I share your frustration in that regard as well. There's a series of workshops been going on. 2 have taken place. There's a third one week after next up in North Wales, and that's been a really interesting experience because I've attended both of those workshops where we've explored this. Now, there's clearly a lot of activity going through those STECs. From a variety of sources, a lot from primary care, and like I said, there is definitely some pull through from ED, and what there, as you highlight, what there isn't necessarily very much from us. Now, there are some that are better than others, and there are some where we are basically barely getting over the line. Like I said, but those workshops have been really interesting in kind of flushing that detail out. John Chippendale in my team has been on the faculty that's been presenting at these workshops and illustrating the potential opportunity they have. And it's been good to be in the room because I've genuinely seen light bulb moments for people going on in the room thinking, oh, actually, there is really something. Especially, you know, what he makes in the presentation is a correlation between if we don't release ambulances, you're going to be busier. And so it's in your interest to release the ambulances because we'll defray that activity more effectively. So I remain the eternal optimist that I genuinely feel that the team of Tracy and Rachel Welch Government are really in a grip on this thing. And I think the next few months will kind of illustrate as to whether we are going to kind of turn the corner on that. But the workshops, I think, have been effective in kind of flushing.
Well, that's good to hear. At least there's something happening around the
there's definitely something happening.
Yeah. Okay, thanks.
Thank you, Chair. I mean, Kerry's made some of my points, but I was concerned reading your report, Jason, because it does show a deteriorating trend again, doesn't it? We did see an improvement in December, as Lee has highlighted, but January and February has gone the other direction. The question I had was around paragraph 10, where we talk about modelling 3 scenarios for CASC. And I just wondered, I realised the work is due to be completed at the end of March. So when will we have sight of what those 3 modelling exercises show, please?
Yeah, I'll answer that one. So we've got Optima who are working on that for us. It should be with me, you know, today probably next week or so. I'd say probably that would come to F&P probably first in the first instance, but it would, you know, I think this type of report is the one where it would then come up to a board level. Yeah, the CASC is happy with that time frame in terms of, you know, it was a request he made probably only 2 or 3 weeks ago, to be honest, to have it, because just to give a bit of context, the starting point from the CASC was to continue with a set of performance targets for next year that was same as this last year, which was, you know, reach 65% raised by Q3 and, you know, handover delay to be down by to 12,000 hours by, you know, Q3. And we said, look, it's not, we can't sign up to some of those things because there's so many variables, and hence he's given us the leeway, I suppose, to paint some pictures in terms of what performance might be looking like, depending on various external and internal factors. So yeah, it'll come back to F&P in the first instance, and then on back up to here.
That should be really interesting, shouldn't we, looking at the different scenarios, because it is slightly different, which is why I asked when we'll have sight to that. Thank you, Rachel.
Paul, did you want to come in? Nobody done. Any other questions? I've got a couple of things. The fit to sit I noticed in there as well, it seems to be very varied, a bit like the SDEX, which I was also going to mention, but Paul's already brought that out. But you know, it's a good plan, but it doesn't seem to be being implemented universally with the same degree of enthusiasm.
So there, I mean, it's fair to say, Chairman, there is variability in its application. Liam, you might be closer to this to perhaps just offer a few reflections.
Yeah, so we've had feedback from colleagues across the country in respect to fit to sit and how it's applied. So we have national criteria. It's in our gift to define when a patient should be considered fit to sit within the hospital environment. For some hospitals, that is not always supported. The reasons that are given are variable, and we've actually asked for some more direct feedback from our colleagues to get a better sense. So in some instances, it will be about clinical risk in the department. So there will be medical cover that will be defining very clearly they don't want any additional risk. And when you sit and look in the ED department on occasion, you can see why that might be the case. That doesn't help us, but understanding the position is important. We've had a couple of examples where rationale that has been given is not a rationale that we would support. So one recent example given in WAST Live, in fact, was an age profile, and age is not a definition of frailty or acuity of presentation. So we are looking to do more work on that to highlight it further. We are very conscious that the College of Emergency Medicine is being quite strong at the moment in challenging the risk within emergency departments and ensuring that that risk is being spread across hospitals. That's not just a Welsh consideration, that's a UK-wide consideration. So I think that's the stuff that's playing out in the departments that our people then end up having to deal with. What we're really keen to do is make sure we keep the patient at the centre of what we're doing and that we keep the right relationships on the ground. So we have put escalation, again, we've reinforced the escalation routes that our staff can follow if there are direct concerns and there's a local manager or if there's a local clinical lead in the area to flag and deal with it on the spot if possible.
Right, I think that's fine. Anything else? I know, Bethan, what we've done in previous meetings is we've asked you to kind of comment on this topic outside of your normal feedback from Quest. But shall we go back to the old mechanism and just complete, when you do your Quest update, you can cover this point again. Brilliant. All right, good. So I think we're all done. We're asked to note the report and consider whether there are any further actions. And actually, there are a few other actions that we're still looking at. They are a bit marginal, but every action potentially has some benefit, doesn't it? So there'll be more to consider with SDEX and other things we talked about this morning. So thanks very much, Jason. And we'll move on to the next item, which I think, Rachel, it's yours.
It is, yes.
Okay, MIQPR.
Thank you very much. Obviously you have had a chance to read the report, and apologies, this is usually one that, or often one that comes a little bit late to board, so apologies for that, but it's just trying to get as much of the most recent data into the report for you as possible, so as much of the February data as possible. So just to, I won't pull out particularly what we've said in the report around our EMS service, because we've just covered that in quite a bit of detail, but as always, I will just pull out a couple of issues around 111. As you can see from the performance data, call handling still, continues to be pretty good. It hasn't quite met the target in February, but it, compared to previous years, we are in a much more stable position, and that is partly because the team have done some really good work on, recruiting up to commissioned levels of staff, but also a huge amount of work in terms of process improvement and efficiency within that system. I just wanted to flag, I suppose, that that we touched on the CAS replacement earlier. That is having an impact, both in terms of the ability of our teams to, we've had to pause recruitment because the training teams just don't have the capacity to onboard new members of staff for a period of time. And of course, our call handlers and clinicians are being abstracted away from their duties to train on the new system. So there's a bit of a double whammy in terms of staff not being available to either answer the calls or then to ring back patients. So we are expecting and will see a slight deterioration in those performance metrics in 111, but the commissioners are aware of that. We talked about it at length, I suppose, and to give assurance that we had to take those actions in order to get the CAS in that very quick time. And as you said, Bethan, the work going on in all of those teams is phenomenal, and we're all extremely grateful to the teams for the discretionary effort as well that they're putting in through this period, to be honest. In terms of our ambulance care service, we continue actually to see some quite good performance there in terms of renal and oncology achieving the target, and the kind of outpatient type activity is pretty much near to target, and there continues to be a lot of work within the service to improve on those performance indicators. So that's good. I was just going to put out a couple of other key things we didn't mention in terms of our EMS service, how well we've been doing in terms of production. So I will just call that out. We have maintained a very small vacancy factor through the year. We've been able to produce, more hours on shift. The abstraction rate, which is, we try to benchmark and say we should be abstracting about 30%, but we've pretty much hit that for the last couple of months. So that, again, a big credit to the recruitment teams and the EMS leadership to being able to get that done. And the other couple of things I was just going to pull out from a kind of a staff perspective is that we have seen an increase in PADR rates, which is really good to see, and also an improvement in our stat and manned rates, and that continues to be a focus within the organisation. And I think it's quite pleasing to see in the IMTP this year as well, that as well as concentrating on PADRs, once a year conversation, actually what we need to do is make sure that those conversations, a culture of conversations, is happening all through the year. So that'll be a kind of a focus for next year. So I'll pause there and happy to take any questions, Chair. Thanks.
Good. Okay. Questions, Paul?
Yeah, I was going to ask about the commissioning of less call handlers next year.
Yeah, so
I just wonder on what basis, when you look at the activity and you look at the response.
I think, I mean, this is something that we certainly will be picking up with Stephen now in his new role, and we'll be kind of reviewing within the new commissioning arrangements. I think in essence, I mean, Chris, it's largely a function of, here's a budget, what can we afford within that budget? But we know that there's been an uplift to that budget, along with all others of the 3.67, does give us a bit of scope to have some further discussions with commissioners as we start into next year. So that conversation hasn't completed, and we've also committed in our IMTP to do a demand and capacity review. So we will be funding that collaboratively, and work collaboratively with the commissioners to then get a better, a bit more of a robust data that underpins, the level of resource that we need. Notwithstanding, and we were talking about this yesterday, that the new CAS system actually is potentially bring some quite, important efficiencies into the system, which we'll need to take account of when we do that.
It's just interesting, isn't it? We're starting to be commissioned for one, and then immediately there's a reduction in.
I mean, that's a hang back to the current commissioning arrangement. So yeah.
So it's not a done deal yet. It's not confirmed. Okay.
I mean, it is confirmed from a sense of day one, but we know that Stephen is really keen to, once he takes over the reins, to start having those conversations with us. Yeah.
Okay. Any other questions? Can I ask about signals? I don't know, Angie, whether you're going to mention it later on in any of the papers, but we're kind of flat really on signals, aren't we? Yeah. We were making good progress, but we're still some way from that 6%, which I know the Welsh Government is still looking at us to achieve for next year.
I'm happy to, I mean, it's actually gone down again, so we're seeing a steady decline again. We do know that there are seasonal challenges with that, Colin, and I think when we move into the NHS staff survey paper and you look at the feedback from our colleagues around potential burnout, stress, additional work, I don't think we can see it without looking at the wider context. And I think hopefully some of the work we're going to be doing in the IMTP next year, well, on Monday, will show that work around. We have to look much more holistically at our approach to sick absence. So we have got our processes in place. We are really doing that work, but now it's really about the focus on our leaders and managers, the check-ins, the culture, because it's that really seeing your manager regularly to make sure you're doing okay. Yeah. So absolutely acknowledge, Colin, there is so much more to do. And I know Rachel and I have talked about the challenge of that particular target, but I think it's positive. We need to have the target, but we also have to recognise what we're being told by our staff and respond to it.
And the other question I was going to ask about was actually just to ask about basically how we actually measure it. But we have a metrics here on conveyance other than to an emergency department. Yeah. And again, I know from communications with the minister in terms of objectives for next year, that is something that they're going to be focusing on, because it's kind of the evidence of our strategies. And I just wonder, well, there's two parts to the question really, is how do we actually measure that, and is it something that we're able to to influence?
So two things on it, Chairman, if I can. So I'll bring Rachel in to talk about how we measure it.
I missed the first bit.
How do we measure conveyance other than to an emergency department?
Yeah. And again, look at the numbers. We got 11.4%, so it's like very accurate, and then 12.22% and 11.62%. So there's clearly some arithmetic going on there. But I'm just interested in how we measure it, and it is a focus, I know, again from communications with the government about objectives for the coming year.
So I'll ask Rachel to comment on how we measure it. But what it is true to say is that we are giving active consideration to the definition of what is considered consultant close, conveyance, non-conveyance, all those kind of things. Because again, when we get into a conversation perhaps later around the IMTP and developing further the journey we've been on for a number of years now with the clinical model, so as we go to the next phase of the journey with the clinical model, it will require us to measure things slightly differently. But perhaps more on that later. But Rachel.
I mean, the conveyances to places other than an ED is a definition about conveyances to minor injuries units, acute medicines unit, SDEX. So anything where we take a patient to a hospital, but it isn't the ED of the hospital that we're taking them to, and it's a percentage of all our verified incidents. So it's not a brilliant indicator on its own. And interestingly, that was the ministerial target for last year. That has been it's been removed. That particular metric is no longer in the performance framework for Wales for next year, because I'm not sure it really gives a whole system picture, because actually it's not about, we don't want to be conveying patients at all if we can. It's about, and how many do we prevent from conveying to anywhere. So as Jason said, part of our new response model, we want to work with commissioners and with Welsh Government to define a new set of metrics that kind of a bit more meaningful. So we've said, for example, haven't we, that we might have an ambition to double the number of patients that we safely maintain within their home or in the community. That's not a metric that we have at the moment, but it's that sort of thing that we want to be able to define and then measure.
That's good, because I felt it with that.
Yes,
When I looked at it, I
exactly.
thought, well, I'm not sure what we're measuring here.
Yes.
And if you've got something there which you're looking at and there's a target to be improving and it's not,
Yes.
and you kind of think, well, hang on a minute, actually, are we doing ourselves a disservice by recording something which is a bit kind of loose?
Yes.
Lee, you want to come in and then Andy?
I did, Chair, thank you. And this kind of leads on to some of the elements that you left with the board at the last meeting, actually. And I've very much been taking this forward with my team. And hopefully this is something that we can start to do with commissioners and those, of course, are interested in measuring. And I do think that the percentage measurement days, I think, have to be numbered, because particularly with a system that's in such flux, the percentage measurement is misleading, and it's misleading on experience, I think, as well. And because of that, it's also difficult to buy our people into it, because they are not seeing it as attainable or improving. Yet, of course, underneath it, when we get into the raw numbers, we actually know that there are some very good stories that can be told. Don't get me wrong, I'm not suggesting that there's not work to do, but there are different stories to be told in the raw numbers. And so I've already been talking to my teams about getting into volumes, and our ambition, particularly as we, last time we talked about the hear and treat, ambitions need to be around, in terms of volume, resolving more activity safely without an ambulance, resolving more activity safely without attending the emergency department. And I think it might be a bit of a challenge first for ourselves to also start to make this shift, because we've talked percentages for so long. But I think it's a really important point and something we need to try and take partners with, I think, on this one.
I completely agree with Colin, and I suppose this is starting to mean is flush out is the very nuance on what it is we're trying to do. That these fairly arbitrary measures, I think, don't necessarily paint the full picture. And then, the other bits to consider for me is this: when we do push on and doing more things remotely, inevitably that means our ability to see and treat and manage people after a face-to-face will naturally come down, because there will be less patients, because we're doing more remotely. And so our measurements have to be ready to kind of capture that, and not necessarily look as though we've had a drop in performance, which a percentage measure would show a drop in performance. Well, that's because we've done better somewhere else and we're not doing that here. So it really just kind of detail the complexity.
Does that suggest that there'll be a slight change to some of these data on this reporting sheet that we
Yes,
generated?
there will be. So,
Okay.
I mean, what we, I should have said that at the beginning, Chair, it's a good point, because we go through an annual cycle of reviewing these metrics that come up to board. So we have got that agenda for the next few committee meetings so that, the committees can consider it, but we will come back with a revised set of
Okay.
metrics, yeah.
Right. Yeah, right. And actually, Andy, I mean, it's a bit off the piece, but I mean, the point you just made is really important for us as non-execs, and when you're monitoring performance, to kind of be able to join those dots up, because you're quite right that if suddenly, we're doing marvelous things in the call centres to avoid dispatching ambulances and things, then actually, if we're not careful, we might find that we are actually conveying more to hospital as a percentage, but only because actually the raw numbers are going down and we're dealing with other people in other ways. So
the ideal circumstances, we have a 95% plus
That's right.
conversion rate in our ambulance.
Exactly.
Because we're only sending them to the jobs that need to be conveyed.
That's right. And I'm very mindful of a presentation you gave, but that was exactly your point, that you only send an ambulance where you're pretty certain that you actually are going to convey, because that's what they're for. Okay, good. Sorry, I've taken the on. Sorry, Liam.
Yeah, no, just it's additional to this, and it's to note that we have got the clinical networks coming into play from April across Wales. One of the things that will be helpful, and I hope in that, is that we'll have linked data sets that sit at population level and by specialty. And what that will enable us to do is get a better sense of when a patient is discharged by us in any form, or when they're advised to access healthcare in a different way by us, then that linked data set will enable us to see where that person turned back up. So we actually, at the moment, a lot of the measurement we have is by service. So we see very clearly what's going on within our service, but we don't necessarily have that full view of the pathway about what happens where that person turns up again. If they turn up again, if we think about injuries such as a fractured neck of femur, we don't always have the correlation between the long wait and what their outcome is and how long they've spent in hospital. So those clinical networks, I think, will be really important to us in helping that shift away from, if you like, performance metrics to truly clinically driven quality metrics.
That's good. Okay, fine, thanks so much. The other point I was going to make, I know, Chris, you'll talk about it in your finance, but we shouldn't let it go unnoticed, and we should notice on a number of occasions how well the finance has done, on this. We look at balanced budget. Again, last year we did it. This year we went into this year with a £6 million savings, and I seem to recall, and other things. And we all thought, gosh, that's another big challenge, and you've done it. So well done. Big well done. And I'm sure you'll talk about it a bit later on anyway in your finance papers, but you can't have too many positive strokes, can you? Yes, Estelle.
Thanks, Chair. It's only, and notwithstanding all the good points and the challenges in the report, I'm just looking at the slide pack, and apologies because I'm on an iPad, I can't actually see what slide number it is, but it's the one on patient experience surveys. Under the quality, safety and patient experience, our patient section of the slide deck. And we obviously, as part of the Civica central sort of patient experience gathering software, we ask people for their experience of us, and we've got some benchmark figures there about what constitutes good, and then we've actually got the response rate. Now, I don't know what the raw numbers are, Liam, in terms of how many responses we're talking about here, because my suspicion is it won't be many, but I think it just brings it back into sharp relief that those people who do take the time to fill out these surveys, and I suspect obviously they're often people who've not had a good experience. It does give us a sense of the impact of some of the challenges we've been talking about on the experience of patients. So I know there's work going on, and certainly Liam and I are actively involved in the 111 Wales Online, for example, which is the lowest score there. But I just wanted to bring us back to that, because actually at the end of all the sausage machine of all the challenges we have and everything else, we have patients who are having a poor experience, which I know we know, and we know very acutely, and we feel it very acutely. But I think it's just quite stark when you see it in those numbers, recognising that the baseline figure might be quite low, Liam, and I'm not sure what that is.
So just to say, that on your iPad you can't see, but it does have the number of responses on there, and you're quite right. It is very small. So for 111, for example, it's 13 responses. So we and I know part of the work for next year is information governance issues, particularly for some of these. So we want to increase the number of patients who provide us with that feedback, because it is really rich. I completely agree. Yeah.
Yeah.
So assurance board that this was picked up at the Information Governance Steering Group on Tuesday this week. There is a level of commitment, for want of a better phrase, to try and get over the information governance issues that will then facilitate this. We are taking learning from one of the English trusts with slightly different legislative environment. The English Ambulance Service Trust has been able to make more progress than others. So we're kind of looking and learning from them as well. But it is recognised through the national, as well as obviously the work we're doing, that we're caught by a specific around consent on IG, and it's a really important thing for us to work through, because the consent principle is beyond just use of Civica. It's about how a patient's data or how a patient is accessed following an episode of care in any form. So it's just a very careful negotiation and process that we need to go through.
Okay, good. So we asked to consider whether the report provides sufficient assurance, whether we need any more information, and any remedial action. I think we've had a good discussion about that, and some activities and slight changes for the future. That's all good news. So if we continue with that, we'll move on to item 10, which is to Trish to risk.
Thanks, Chair. Chair, you've got the risk report in front of you. Just to reiterate that all of these risks on the corporate risk register have been through a period of review since the last board meeting, but have also been through all of the committees that have reviewed these individually since we met. So there has been really excellent engagement on both this BAF and since this BAF as well. And actually, the executive leadership team yesterday, we were able to reduce the score of 2 and close 1. So actually, there's been some really good movement. And I think what you'll see in this BAF is there is a sea of blue, and that blue means new additions, new actions, changes from what were actions up to control. So there is good movement through all of these. Highest rated risks 223 and 224 relating to patient harm remain static in score, but again I think it's important to note that we do spend a lot of time on these at the Quality Patient Experience and Safety Committee, and you'll see from Bethan's report to the board that there was assurance that these have been monitored, they've been reviewed, and that we are talking about them. They are driving our agenda, notwithstanding that the score remains as it is for the moment. They also appear at the other 2 committees, the Finance and Performance Committee and People and Culture Committee. So they are getting those eyes on, and they are also discussed at executive leadership team. With respect to 160, the sickness, that is also, we've just discussed some of that there through the MIQPR. Again, it gets regular review at executive leadership team, People and Culture Committee as well, and Paul will talk to that on his report to the board. Risk 163 is one of the ones that we reviewed yesterday. This is in relation to trade union partnership relationships. I wonder if I can just ask Angie just to sort of indicate how that might move in this next quarter.
Yeah, happy to do that, Trish. So I'm hoping my trade union colleagues will agree with me on this one, but definitely the work we've done over the last quarter around the local partnership development programs, the engagement, the feedback, I really feel that this risk is reduced, but I'll always recognise it's a volatile risk, it's dynamic, it depends on some external factors, but I really think that the intense work, the response to the ACAS recommendations and the active engagement in terms of particularly with our local managers and local trade unions to come up with collective solutions has been exceptional. So I'm hoping that colleagues will agree that it should be reduced.
Thanks, Chair.
Okay.
Just a couple of other things.
Yeah.
Risk 201, which is our risk to our reputation. We've had quite a few individual deep dive sessions on this since November. We've actually also got another one coming up to the May People and Culture Committee as well. So that will continue to be reviewed. And the last higher rated risk for the board is the civil contingency response. And you've got the detail there that again has gone through the review at the Finance and Performance Committee. Last thing on this, Chair, is the approval by the board of the risk management policy. It's one of those handful of policies that the board must approve. It's been through the audit committee last month, you'll see that it is recommended by the Audit Committee on their report. And just to say, we have got a short review time. We've got a short review time every year because there's going to be a lot of work on the strategic BAF this year. So we just want to make sure that that's reviewed and updated to bear that in mind.
Okay, thanks, Trish. Any questions, comments in relation to the risk? It's all very comprehensive. It's good to know that they're constantly being reviewed. We're asked to consider the report, which we've already done, receive assurances, which I think we have, and we're asked to approve the policy. So are we all content to approve the policy that was contained in the papers? We are. Thank you. Good. All right. So then we're on to number 11, after which we'll take a short break. So over to you, I think, Angie, for start serving.
Very happy. Thank you, Chair, and thank you for allowing us to go on at late notice, bearing in mind we'd only had the results back at the end of February. You have 3 documents that we've shared with you, obviously the high-level report, the dashboard, and then I also shared the presentation, PowerPoint presentation that we gave to the executive team because I felt that was really helpful in terms of pulling out the key facts. The dashboard, obviously, you can go in and interrogate slightly and it will give you a little bit more information, but I'm hoping for this session that we can just really think at that high level about what this is telling us. I'm going to give you a sort of couple of key highlights from my perspective, and then I really would like to open it up to get views from colleagues. So key things to note, 1,006 colleagues participated, so 23.2% response rate. This does not include volunteers. Volunteers are not participating in this survey. And engagement scores, which is probably the key factor that is looked at across the NHS in Wales. Our engagement score has gone down slightly from 72% to 67%. And across the NHS broader, it has gone down from 75% to 73%. So there's been a slight dip across the board in terms of engagement, but perhaps not as low as we might have envisaged it would be. Other key points, I want to start with the positives. So some really positive and reassuring feedback from colleagues who participated around how they feel about their work, the fact that they trust their colleagues, the fact that they care passionately about their patients, all really positive work, and the fact that they go the extra mile. I don't think we can lose that one because that's the discretionary effort, which you also have to see then against potential burnout. But we do have colleagues across the board consistently saying they go the extra mile and also supporting each other. So you'll see in the presentation the sort of top 10 of positives, which I think were really reassuring. When we talked about this at the executive leadership team meeting, we also looked then at some of the negatives. And again, in the conversation we've just had, Colin, around potential excessive workload, potential burnout, concerns in terms of safety and how they feel in the workplace, and concern about potentially concerns not being dealt with if they raise them. If I can be positive about this, none of this is a surprise because we've had this insight and intelligence through the roadshows, through Hive surveys. So I feel really reassured that we've been having this sort of touch point and health check with our workforce for a number of months, and it's not telling us anything that we weren't already aware of. The issue now is to make sure that our colleagues can see we're dealing with these issues, that we're listening and we're responding. So once again, in the documents, you will see the commitment that we've given around how we cascade and share this information openly with colleagues, the fact that we've appointed directorate leads to really sort of embrace and take that role, actively championed by their director and their senior managers, but having those frontline directorate leads will make a difference as well, because on the 8th of April, we'll get the next level of detail, which will give us much more rich intelligence by directorate. So again, we can really start to hone in on, are there particular parts of the organisation where we need to do more tailored, focused work? But organisationally, I feel reassured that the work we're doing, we have done on the people and culture plan, but also the IMTP for 24-25 really relates to what's been said in here, particularly around health and well-being, but also in terms of keeping our staff safe in the workplace, in terms of their emotional, physical and psychological safety. So they would be the key points I'd make, but I'm really happy to open it up, Chair, to get input and perhaps as well really think about the role of the non-execs as board, in terms of that board role as well.
Good. Thanks, Angie. Right, so let's open it up then to any questions, comments. Yeah, Paul.
Yeah, I want to reiterate what Angie said, really, is a lot of this we already know. I think there's a couple of things that stand out. For example, 29% of respondents said the last time they experienced harassment, bullying, that they didn't report it, or a colleague didn't report it. And I think some of the things we put in place, like the Speaking Up Safely platforms, the Guardians, the management training that we've undertaken, the difference we've got around PADRs, I think some of that should help around that area. It's interesting to see how highly positive the positives are. You know, they're not just positives at 56%, they're quite high positives, but there are still obviously things to be done. But generally, I think it's a fairly positive report, I think, considering where we've been in years past. The engagement, I know, was slightly down, but it was much further down than that previous to last time. So I think there's a trajectory of people engaging better, being more open, and I think we've got a lot of things in place now to help us reassure staff and give them the confidence to speak up, etc.
Thank you, Paul.
Yeah.
Yeah, and can I just say, obviously, at the time that this survey was live, we had not formally launched the Freedom to Speak Up Guardian post or the Working in Confidence. It happened just after. So thank you.
Good, thanks. I mean, and I know Damon wants to come in, but shall we just go to Hannah first? Not quite sure which hand went up first, but Hannah, shall we go to you and then we'll go to Damon?
Thanks, Colin. Hi everyone. Hi Angie. Thanks for this. Really makes really interesting reading, I think. I just had a question. Looking at, let me work out which slide I'm on. Slide 9 or 10, I think. Looking at and the question around line managers. So looking at compassionate leadership. So you've got obviously 3 different questions, but you've got kind of you've got generally a sort of 9% strongly disagree, 10%-ish disagree, and then a sort of hovering around the 20% neither agree nor disagree. So if I'm thinking about that in terms of numbers, I'm thinking that because you said about 1,000 people completed the survey, right. So that means that about 600 people are having a good time with their line manager, and about 400 people, their line manager's not really adding anything to their experience. And for some of those, they're actively displeased. And I know that we've been on a journey in terms of the compassionate leadership, and I don't know how this would compare to sort of previous experiences of line management, but I just sort of wondered what your take was on that, really, and what we think the next steps are in terms of making sure that a bigger proportion of line managers are able to do what I would say are fairly standard line manager behaviours that we would expect everybody to be able to demonstrate.
Yeah, happy to answer that, Hannah, and it's quite opportune because obviously we've been doing some work over the last year around leadership and management development, but we've just taken that to the sort of next stage. We're just about to launch our WAST way, which will be our leadership and management program, and some of that really focuses on what I would call the basics of management, which are really understanding your staff, being able to support them on a daily basis. It links to the comments we made earlier about those check-ins and how often they're actually happening. I mean, really what I would call the fundamentals of management, making sure that they're in place. And then alongside that broader work around compassionate leadership, but in a more structured program. So it's absolutely on the agenda. And I think we would acknowledge and recognize we have done pieces of activity around development, but it hasn't been as holistic as we would have wanted. And again, it has probably been in very sort of bite-sized approaches. Jason and I, when we were at a session a couple of weeks ago, were talking about a more immersive type of development for new managers. How can we really give them that immersive experience quite quickly in their career because they may be new, and for all those sort of basic things you need to understand if you're going to do it. So we absolutely recognize it's an area of focus. And again, those were the types of results that resonated with us as well in terms of making sure we address them.
Great, thanks, Angie. And I think that sounds particularly positive around the new managers, because I think it often people are promoted into a managerial role, but without necessarily ever having had a lot of input in sort of what the core skills are of that. So that sounds really positive. Thank you.
Good, thanks, Hannah. I know, Jason, you want to come back?
Yeah, thanks, Colin. Forgive me, Damon, just jumping in on this. Just in response to Hannah's question. It's a great question, and of course the response rate does give us, some food for thought. And Angie's just described some of the thinking we've already got about how we help managers. But I suppose I just want to inject some balance into this, in that there will be many of our managers out there that are doing great stuff, and it's a tough gig. If I think back to when I was a first line and a middle manager, you're squeezed from both sides. So these are tough roles that our people have got, and many of them we know are doing great stuff. What we want to do, I think, Angie, through the development you've described, is help people to be even better and even more effective at what they're doing in leading and managing their people locally. And of course, many of those responses here, we have to remember, of course, will be contextual to the circumstances or the experience that the individual responding to the survey had very recently. So that's not to say that there isn't some poor practice, because of course there will be, but it will be contextual to their experience at the time, whether they've been performance managed for an issue or they've been subject to a conduct issue or something. All those things play into how people respond. So I'm not for 1 second saying that we haven't got work to do to help our people be even more effective at what they're doing, because we have. But I suppose I just want to balance it off that there is great stuff happening anyway, and we just need to help people, with the journey.
I think that's right, and I would just then come to Damien that the thoughts that go through my mind are, we know from other surveys, the sponsor of the surveys, that the people who've had a negative experience anywhere in life, and hospitality, wherever it might be, are more inclined to fill in surveys than people who've had happy experiences. So it is always possible that the responses are slightly skewed to a sort of a negative attitude to some extent. The other thing I think is going to be really interesting, Angie, is when we get the breakdown by directorate. That's going to really start to inform our thinking, because one of the things I really worry about going forward strategically with HR in other places, and it'll be the same here, is that most people, I think, learned the skill of being a good manager by the experience they receive themselves and the experience they see that others experience. And whilst half of our workforce are working in a very public arena where they will still experience that, i.e., frontline staff, an awful lot of our corporate staff are working from home, and therefore they're not seeing that kind of environment that people used to see pre-COVID, when we all worked in offices and we all kind of rub shoulders on a day-by-day basis. So I think there'll be a lot more thinking that we will need to do when we see the breakdown.
And just on that point, what I should say as well is our managers themselves are saying we want more development.
Yeah.
We want to develop our skills in this space, and I think that's really helpful then, because actually this is about wrapping around the right support for people, whatever level they're in, but particularly that sort of core management group to say, we will ensure that you have all the access and skills and support, right role models, etc. So it's definitely been done through a lens of raising capability and confidence rather than a punitive. So I absolutely agree.
Good. Okay, I'll come to you in a moment, if you may, and over there, but let's go to Damon first. He's been very patient. Thank you, Nathan.
Thanks. I just, I think the first question I was going to have, I think you just answered, it was in respect of understanding departments which are happy and things. So that information is to come, I guess, then.
Yeah, so what we will get is at that directorate level, although some directorates, because they're small, we can't get it. So with those particular directorates, we're going to do something more on an organisational level, but also work with the directors themselves and their teams to think about what the issues are. But yes, with the larger directorates, I think it's over 20 people, they will have more tailored. But again, it depends on the response rates for those areas. And of course, what we'll also do, Damon, is correlate it with what we've had through either Hive or roadshows, because we have got a lot of rich information. But yes, we will be able to drill down, and that's why the directorate leads will be so important.
Thank you. And the other comment I was going to make was we've now got the ability, the technology to we've got the digital online courses which are mandatory as such. I'm appreciating that not everybody wants to comment. You could always have a non-applicable, but do think to get really good data, we could make this now a mandatory
process for the staff to complete in some way, and at least you're going to get that response back.
Well, do you know, I think NHS Wales, HIW would love it if it was mandated, but at the moment there is no desire or nationally to do that. I think they are hoping that people will see that action is being taken, so it gives it more credibility, and then colleagues will participate, because the next one will be in September, and I hope we do see a bigger increase, but at this stage there is no desire or nationally to mandate it. Locally, we would try and really actively encourage, but again, I'm not in the space of wanting to mandate anybody to. I'd like to think that they would want to participate, but it's a good point.
Good. Okay, so I've got the order. I think probably Kerry first and then Bethany. Is that all right?
So I think it's really reassuring for us as a board that actually a lot of the issues and insights that are coming out of this that you're already focused on in people and culture. So I take a lot of assurance from that, and I think Angie, you and I had the conversation, actually some of these insights, they're going to get worse before they get better. So, and we have to see the positive in that element. So that's just a reflection for me. So I've got two questions. One you alluded to earlier, Angie, around this, the 73% of staff that come to work but not feeling well enough to come to work. That concerns me. And it concerns me in the context of the pressure for us to bring sickness down. Now, what we don't want, personally, I don't want as a NED, is people coming to work when they're not well enough. So just interested in your reflections on that. And then my second question is, there's a lot to do and we're very busy. So it's around the capacity to respond. So in terms of the work that's already happened, obviously we've had investment there, but I suppose I'm just looking for some assurance that as we put these challenges on the table, that then we have the capability and the capacity to respond.
Okay, happy to answer the first one. So it's interesting, that particular question that you just talked about, the coming to work when you're not well enough. With the directorate leads, we've done some work with them around switching that on their head and thinking about what might be the barriers to that. So we're doing that with the directorate leads. Lee and his team had a senior leadership meeting this week, and we used it as, again, one of the examples to sort of really unpick. So what's causing that? What's going on? What does it mean? Because some of the challenge we also have is because colleagues care passionately about their work and they want to do the extra mile, there is a slight conflict. There is a conflict in terms of people wanting to come to work. And I suppose if you answer that question and think, have I come in? We've just got to get underneath it a little bit more. So, and I think we weren't sure. Yeah, it's definitely going to need a bit more probing, but the directorate leads will definitely be focused in on some of those questions that we need to understand more. Because absolutely, this balance between sick absence has to reduce. You know, we're out of kilter with the rest of the NHS in Wales. We have to do work on that. The way we do it, the support we still provide, early intervention, getting people to avoid them having to take time off where possible, and the role of the manager again, you know, that key role. So we see the link, and it's top of the list in terms of the conversation. So I can give that assurance. I think as well in terms of the lots to do, if you've seen what we've put out, Jason put the note out to all staff this week, we put it on Siren. We've tried to narrow it down so staff can see where we are putting our energy and attention, because otherwise it's too overwhelming, which is why we've then said at directorate level, if there's other things that you want to do, that's fine, but let's not overcommit and then not deliver. And let's see if we can link it to the work we're already doing. And I feel relatively confident that we've put additional resource in to the speaking up safely area, the raising concerns, which was probably the area I had most concern about in terms of capacity. So I feel reassured that we've put some capacity where we needed to do it. That helps.
Okay.
Thank you, Chair. Both my questions have been asked by Hannah and by Kerry. However, there are two comments I'd like to make. The first one is, I really like the phrase culture of conversations, so that we develop a new approach really that will further supplement the PADR. So I welcome that. I think that's fabulous. The other thing for me was a question around perception versus reality, which is always an issue, I think, in these sort of surveys. And the one point I'm looking at, one question that brings that to life for me is the question around whether the organisation acts fairly with regard to career progression and promotion. And only 37% have said yes. Now that's really stark, isn't it? And that's worrying, I'm sure, for all of us. However, my question, I guess, on that is there a part of a communication or a presentation thing that we need to rethink about when we are looking at appointments, because people's perceptions become their reality and often those perceptions are inaccurate. We know that. Hence my question around communication or presentation, because that is worrying, taking it as face value.
And it's a great question, and we see it across the NHS more broadly, and we see it in the NHS in England and in the ambulance service more than others.
It's everywhere, isn't it?
It is. We don't take it, we don't disregard it though, because even in some of our culture reviews we've been doing, one of the things that's come up regularly is this perception of favouritism, that things aren't fair. So again, linked to the work about how we communicate our policies, how we're applying the policies, how people obviously have the roots of respect and resolution if they think things are unfair. So really trying to keep reiterating fairness, working with our trade union colleagues again to make sure that if we're being told that there are potential concerns, how can we address those? But there's also I've got to talk about the history, that it can also be quite challenging if historically there has been a perception or a reality that something was seen as favoritism or whatever. Really trying to reset and say this is now is really hard, but absolutely recognise it, and we see that as a theme throughout the organisation.
Good, okay, Jason.
Thanks, Colin. I mean, I agree with everything that's been said about the fairness issue. I suppose there's just another side to the coin, which is just worth ventilating, which of course is that, you know, a perception of unfairness emerges when one person isn't treated the same as another. But that is increasingly going to happen because we will be taking account of individual circumstances and the environment or the situation that the individual member of staff is in. So the other member of staff in the scenario won't have all that detail and information. Will look at the facts as they see them and think, well, that's unfair. But of course, they haven't got the benefit of the consideration of the individual circumstances for the member of staff that's been taken into account. So there's an inherent tension here, I think, isn't there, Angie, that, you know, on the one hand, of course we need to treat people fairly, but on the other hand, or the other side of the coin, is it's difficult to demonstrate that when you're dealing with individuals and, you know, circumstances that they find themselves in.
And particularly when you don't want to breach confidentiality.
Exactly. Yeah.
And again, this comes back to that key role of our managers and what we're asking them, and that's why that support that they need about how do you make decisions, how do you what would you share, what wouldn't you. But I think particularly around the application of policies, we could do a bit more in terms of how we communicate them, I think. But it's always, that's one that is probably my trickiest one in terms of.
It's really difficult, and that was going to be my question around leadership and management. What is the plan to take that to the next level, because that is key to answering and resolving some of this.
And in our development programme, quite a focus is about making difficult decisions and then how you have to communicate that, and because that's a skill in its own right, isn't it?
I think it's also an important point that fair is quite a difficult word. You know, it's quite an emotive word for a lot of people. Actually, there are lots and lots of different ways in which we can look at whether something's fair or not. The other board that I work on is Qualifications Wales, and, you know, trying to make sure that qualifications are fair and perceived to be fair is a really interesting question. And I think it's quite a sophisticated and nuanced conversation that's needed. We know that we're talking much more, for example, in EDI spaces nowadays about equity rather than equality. So we're looking at trying to support an equitable outcome, even if the support given it is actually quite different depending on the person. So I think it's certainly nuanced, and yeah, possibly equipping people with some ideas for how to have some of those conversations would be valuable.
Definitely.
Thanks, Hannah. Did somebody want to come in over here?
Yeah, Hannah's picked it up really. It's very difficult, isn't it, for our staff to see being treated fairly as not being treated the same. Because you think it's fair if I'm treated exactly the same, when actually that shouldn't happen.
Yeah.
But that's a very difficult concept, I think, when you're, at front line delivering a service, you are having something that I'm not. I want the same. Well, that's not necessarily fair. So it is a difficult one, isn't it? The other interesting thing about that one is the number of people, the percentage of people who have not applied for a promotion or sought promotion. So it's quite interesting that they say they don't think that we've acted fairly, but they haven't applied for it anyway. It's very similar numbers.
Thanks, Colin. A couple of observations then. One is, I think none of us want to be party to a culture where staff think you don't move forward if your face doesn't fit. I think that's the underlying message there. And some of that is around, I think, on the equity fairness bit, is people actually understanding as we move to a more diverse recruitment base. That might be challenging for some people because organisationally people are not necessarily change ready. So we've got some work to do on the diversity front and being change ready. And then the other thing, Paul, you mentioned about people not applying for promotions. One of the things, and colleagues will know this who sit on APC, because I repeatedly use the phrase democratisation of learning. If we look at some of our JDs, and having recently just been going through some job evaluation stuff, we ask for a lot for some jobs where arguably some of those requirements are not absolutely necessary for roles. And therefore doors become closed to people, particularly, and if we look at the more diverse workforce, we know women are disproportionately affected, people from minority communities, etc. So and this is an NHS issue, I think. It's pretty much an NHS issue. But you look at some jobs that maybe an 8A, and you virtually need a PhD to do it, where frankly I wouldn't have got the jobs I had in the past if that had applied then. So there is just something about us thinking very laterally about what are the skills we absolutely value in people, because in terms of when we recruit people, I'm always of the view that you recruit for attitude, and assuming somebody's got a level of gumption, we can teach them the skill. That might be slightly different in, obviously if you apply for a clinical job, you certainly have to have a basic level of clinical aptitude, but in other jobs, that's not necessarily the case. So we have to, if we're going to get a more diverse and more interesting workforce, I also think we need to look at that more lateral view of how we recruit, people being able to cross-fertilise from different teams because they bring core skills, rather than going up a linear line of recruitment where, there may be blockages on that way that mean that you're not able to, plus being able to support people to develop their skills, formalise the knowledge they have, and we've done a lot of this in APC talking about formalising the knowledge people have into qualifications that act as a passport to move them through the system. So just a couple of things maybe for us to think about there.
Good, thanks, sister. Okay, so by some miracle, we are 9 seconds away from being exactly on time, which is extraordinary. So we'll take a break. We'll have 15 minutes, please. If we can be accurate on the 15, that'd be really helpful. And then we want to stretch lunch as well. So 25 past 11, we'll get back if we may. Make a start. Minutes will note the chairman was 1 minute late. To catch up on that, so we are, next item, Rachel, IMTP.
So the first item we've got is a kind of review of this year's IMTP. We did take this paper, or a slightly extended version of it to Finance Committee a few weeks ago. So I wasn't proposing to pull out anything in particular. You'll have had a chance to read it. I'm very happy to take questions. But I think, as always, despite the fact that there are some things that have been slightly off track, some things that we haven't quite achieved in the way that we wanted to, nevertheless, the span of actions and things that we've taken forward this year, as always, have been incredible. And that, as we've said before, is down to the extremely hard work of many of our leaders and managers, in every part of the organisation. So I'm very grateful to all of them for what we have been able to achieve this year. So I wasn't going to say much more than that, Colin, if that's okay, but happy to take any questions on detail.
Okay, any questions on the quarter 4 response? No, I think we're all good on that. Okay,
Lovely.
roll on to your next item.
Okay, lovely. Which is much more exciting.
It is.
Looking forward instead of looking backwards. So you've all had a chance, hopefully, to look at the plan, and we've got some of the appendices here for you. So there will be some even further, more technical appendices which we haven't brought here, but which teams will be ensuring are correct and accurate, which we will send into Welsh Government. So, but what I did want to do is just spend, I suppose, a few minutes pulling out, I suppose, some of the kind of key highlights from this year's plan. First, a big thank you to everybody across the organisation, from execs right through in terms of people who've come together, who spent time thinking about our priorities for the next few years, because it really is a kind of collective and team effort pulling this plan together. And I suppose the first thing to note is this is an IMTP, so this is a 3-year plan which is balanced, and in terms of our kind of statutory responsibility as a board, that means we've met that responsibility, which is really positive. And I'll come on in a sec just to kind of yes, it's balanced, but what sits underneath that, easy phrase to say, not easy to deliver. But that's a really positive first step, and we will be one of very few, I think, organisations in Wales who are able to provide a balanced 3-year plan. So that's really positive. The second thing I wanted to say is that you'll see in the paper that we've, similar to last year, we've kind of tried to frame our IMTP around 3 really important points. One is that it is, of course, absolutely incumbent on us to improve the services that we provide to patients, getting, with our ambition there to get the right care and advice to patients in the right place every time. But actually, almost equal to that is the fact that we must work with our staff to improve their workplace experience, to improve, and just as we were talking about in the previous item, the culture of the organisation, the feelings of psychological safety, and all those indicators that we saw coming through the survey. And we had a really great conversation at execs last week about, reminding ourselves that all the evidence is that actually it's our staff who deliver patient care, and it's unless and until we get all of our staff in the best place that they can be in, actually that's the thing that will drive really excellent patient care and experience. So that is of equal importance. And then, of course, we do have to think about financial and other types of sustainability. We have to do all of that within the context of the resources that we've got, but also some of the other ambitions and requirements on us as an organisation, whether that's around climate sustainability, whether that's our role as an anchor organisation. We'll become part of the Wellbeing of Future Generations Act, so our actions we have to think about in the context of the future of the people of Wales. So we've got those 3 pillars, if you like, of areas of work within the IMTP that are going to be, I suppose, our top priorities. What I hope you'll see in this plan, and that chair comes from a challenge you set us this year, is a sense of it being a much more of a 3-year plan, with some indications in the plan of what good will look like in 3 years' time for our patients, for our staff, for other parts of the organisation, and starting to tease out how we will know when we've got there, some of the measurements and metrics we might use. Acknowledging we spoke earlier about the fact that that is work in progress. We're going to need to do quite a lot more work on that, but hopefully you can see that sense of progress and a kind of slightly longer term ambition towards delivering excellence. So that's the second thing to pull out. The third thing I was just going to pull out then is just, you know, what we're saying in terms of our patient, our services. And I suppose the key is the first line of, you know, of our exec summary there, is that we do see that this year is one where we need to take some more steps at pace to change the way in which we respond to the patients who contact us and who use our services, to better meet their needs. And what that will mean, there's a couple of kind of key things here. One is that we're going to be introducing a new clinical navigation role within our EMSC, so that actually we'll have senior clinical clinicians who are reviewing all the calls that come in with a view to making sure that they're streamed appropriately to get, you know, to have ambulances dispatched quickly where we've got emergency and life-threatening situations, but actually also safely transferring a lot more patients into our remote integrated clinical service, where we think we, you know, got a lot more capacity to do more for patients remotely. So we're going to be expanding the capacity in our remote integrated care service, but also you'll see for patients who do need a face-to-face service because they have emergency or urgent care needs, actually we're going to be expanding the range of types of response that we can provide to those patients, whether that's, you know, more advanced paramedics. Actually, we're going to be committing in this IMTP to looking at our model of mental health response and rolling that out, expanding the level 2 fall service in particular, and you know, Connected Support Cymru is a key enabler for our remote clinicians, but you know, it's also a face-to-face response. So that hopefully comes through the plan, that actually we're going to be changing the numbers of types of responses that we can provide to patients, which better makes, you know, meets their needs. And the last thing just to say in terms of that kind of service and our patients' perspective is that you'll see indications in there that increasingly we're seeing patients who ring 111 or 999 having urgent care needs. And actually it's really incumbent on us to make sure that it doesn't matter which number you access us on, we need to be able to provide the same pathway, the same range of pathways, the same outcomes for those patients. And so we've got a couple of things aligning. We've got our new CAS system, which means that some of the kind of platforms on which our remote clinician, you know, which they use will be the same. We've got our commissioning arrangements that you mentioned, Chair, where we've got 111 and EMS coming together in our commissioning arrangements, and I think we've got a sense that from our new commissioners that there's an appetite to explore what that means for, you know, creating a remote integrated clinical care service, and that's ones and nines together. So I think that from a patient perspective, those are some really exciting developments, which I think will see some positive benefits. From our people perspective, which is the second kind of pillar, I mean, Angie's already, you know, through the work of the survey and through all the information that we've had previously on the people and culture plan, there is a huge wealth of work ongoing and that is, you know, supported critically by us as an executive team to drive forward that workplace experience. And what you'll note is that we have almost re-emphasised our commitment, particularly to some of those areas where we know our staff are saying it's not great. So one is our overruns, you know, so this is something that should be within our gift. We've done some work on that this year, but we've got to do more to almost eradicate overruns. We know we've got to do better in terms of our flexible working arrangements, and that's a piece of work that actually is very positively working this year and will work through continue into next year. And the last one then is the digital experience, that sense of, trying to get our staff able to access and use the digital platforms that we've got a bit more seamlessly and a bit more easily to make their day-to-day life easier. So I hope you can see in the IMTP that there is a lot there around how we continue to work and re-emphasize the importance of improving and enabling our staff to be the best that they can be. And then the last kind of pillar is the financial, or the sustainability pillar. And I think Chris may want to come in on this, but the plan is balanced, but it is balanced on the basis of a £6.4 million savings plan. And that is a 2.2% savings plan. That is not insignificant at all. And we know that future years may well continue to be very difficult. So our financial sustainability programme will continue with perhaps an increased emphasis on the income generation side as well. And what it's probably dotted around a bit in the IMTP, but there are within there, and we've talked to our commissioners about this, a lot of examples of where we're improving our efficiency as well. So right from clinical services to back office services to processes, robotic process automation, for example, is a key priority for us. So lots of examples where we're able to find ways of using the resources we've got to better effect. And the last thing, I suppose, just for me to note is that we do have a letter of support now from our commissioner, which came in a couple of days ago. He's very happy. Jason and I and others have worked with him to talk through this plan, over a period of months. He's very happy and supportive of that. And as you say, actually, it's helpful that he's still going to be in post for at least the next 3 to 6 months to help us kind of take forward some of these issues. So hopefully that gives you a summary of a sense of excitement, actually, that the work, particularly on our clinical transformation, we've been working on this for some years, but the resources that we have this year allow us to move resources into places which make that transformation start to happen at a little bit more pace. So it's exciting. Paul, you asked me just in the break to comment on capacity, and that is a really important point because there is a lot of work to be done here. You'll see, I think it's Appendix 2, we've got a table or a couple of pages which execs have gone through over the last the last week or so to kind of really start to frame what do we want to do when during particularly the first year of the plan. And we've supported that yesterday with discussions about where resources will go to support some of that work. So we've got a resource plan that sits alongside that, some of which is around additional corporate capacity, actually, to support this pace of change. So I don't know, Chris, whether you want to say anything more about the finances, if that's okay.
Just very, very briefly on top of that, as you say, Richard, it's a balanced revenue financial plan. Focuses inevitably on the 24-25 3-year IMTP, but the financial plan focuses inevitably on 24-25 financial year, because that is the only year that we've got a confirmed Welsh Government budget, NHS Wales allocation for, with some assumptions in the technical tables that support the plan going forward to years 2 and 3. Hopefully, when you saw it, it's in reality is no real surprises now, because it's been built up in iterations which we've shared over the last few months, and it's still an element. It's a plan, so the actuals are the important thing as we get through the year in terms of what comes behind that. It's important that it's a plan that we need to approve, but it doesn't stop in that context. Just to add some of that, we had an executive team meeting yesterday, as Rachel's just sort of alluded to, and part of that has been to confirm any outstanding elements that's needed to enact that plan and the resourcing plan that sits underneath it. So there's still work ongoing, and we'll come to next agenda item on the budget setting paper as well about what needs to still be done through Q1 in terms of that. And that conversation yesterday also fed back on some of the aspects that were outstanding in terms of the capital plan, because focus is often on revenue, but on the capital plan. which the covered version of the IMTP plan, which is fine for the IMTP perspective, takes it to a particular point, but then there's more to be done on it, which has progressed, and we'll bring that through in the usual way to Finance Performance Committee in May. The only other thing I was going to say was that, I think you've seen some correspondence from Peter on the back of some of this as well, but we had a good discussion at F&P on the financial plan last week within the IMTP discussion, and some good scrutiny, and hopefully for the questions that were raised, the assurances, responses that were provided were acceptable. So yeah, it's brought to you today as part of the overall plan to underpin it.
Okay, thanks, Chris. Bevan, straight in there.
Thank you, Chair. I thought it might be helpful for me to give some feedback from the F&P meeting last week, as the only member that's here today, I think, with Jolga's absence as well. So the committee were very happy to endorse the plan, is the first thing to say. We recognise that it is supported by a balanced financial plan, although there are stretching efficiency targets in that, as Rachel has said, 6.4 million. So there is an element of risk, but we were given lots of assurance around that. And given our performance on this year's financial management and financial plan, we had every confidence we would be able to achieve it again. Also, as a committee, we gained confidence that the 3.67% revenue uplift would be passed through to us. We felt that this plan did recognise and show our ambition to deliver some of those longer term aspirations that we have, and also moves us towards, a better clinical response model, as already been mentioned. Essentially, we thought there were very stretching targets in the plan, and picking up on your question to Rachel in the break, Paul, part of the conversation we had at F&P was around the resources to deliver this, and also the capability within that as well, and further the trust reliance on so many external factors to be delivering some of what's in the plan. So that was recognised. But essentially, we praised officers for developing a very clear, very coherent and a very ambitious plan that we felt hit all the right notes. So we were delighted to endorse it.
Good. Thank you, Bethan. So any questions? I mean, I would just make the point that, I thought it was really good. And, people know I felt historically there was a bit of a disconnect between the vision and the plans previously. This quotes the long-term vision right up front, and it references it all the way through as well, which I think is really helpful. And I think it's nice to see those tables repeated over and over again for it, where you've got year 1, year 2, year 3, and obviously as you move further out, they're a little bit more kind of slightly vaguer, they're slightly more visionary rather than strategic. But nevertheless, it is putting a little bit of numbers down there. We're actually seeing expectations of potential numbers of advanced paramedics and things, and give year 2 and so on and so forth. So I thought it's a really good evolution of that, and starts taking us in the right way. And I also felt, reading it personally, that it was much more connected to the whole strategy of reducing conveyance and providing more care, and bringing all of the elements like the 111s and clinical support and connected Cymru. Suddenly all of these things seemed to all, for me when I was reading it, I thought, gosh, all of these strands now suddenly are really all connecting, and I'm really pleased to see it. So that was my take on it. Anybody else want to? Sorry. Oh, Hannah, sorry. Do we go to Hannah next and then come to you? Yeah, it's okay. Go on, Hannah.
Thanks, Chair. Yeah, I was going to echo your comments really, that this feels like a really good step forward in terms of the IMPP this year. I particularly enjoyed the recurring green boxes, the what will good look like and what will be different. I think that's a really good way of focusing our attention on the areas to which we've committed. Just a very small sort of typo note, page 42, you've lost the bottom of the what will good look like box. So the box is a bit small. I think there's probably some more writing to come. But yeah, I thought it looked really positive, and it's nice to see those specific in such a connected way. Thank you.
Thanks, Hannah. Jason,
thanks. Yeah, just a couple of points, Chairman, if I can, before the board moves to approve or not.
Oh yes, we may not.
Yeah,
it's finding balance, I think.
So firstly, thanks to Rachel and the team who have been working, for months now, developing the plan behind the scenes. Of course, it's not just Rachel and her team. It's everyone in the organisation, right through the organisation, across and down the organisation who contribute to the development of it. But Rachel and her team pull it together, and that's a mammoth task. So thank you to everyone who's involved in getting us to this point. The second point I just want to make is that in just building on Rachel's comment about the letter of support from the Commissioner, that's right. And to enable that, we had a bespoke briefing session for Chief Executives on Monday this week, didn't we, Rachel, to take them through some of the detail. Many of the Chief Execs from health boards attended, and also some of their directors of planning or others. And there was a good conversation there about some of the developments which are in this, particularly around mental health. We touched on that earlier. You know, the evolution, not revolution, but the next stage of the clinical model that we operate, and how that journey goes to support the agenda of health boards, particularly, and the pressure that we all see and feel across urgent and emergency care. So lots of good kind of conversation there, and support for the direction of travel. Particularly with the pressure across EMS, and as I say, that evolution, not revolution, but the next stage in the journey, if you like, of the clinical model. And the final point I just wanted to make, I guess, is that there is much in this plan this year to be excited about. I think as you're reflecting, Chairman, it starts to bring to life a lot of the work which we've been preparing, the stuff we've been preparing over the last couple of years to get us to a point where we can turn on transformation, if I can describe it like that. So it feels like this feels like a plan and a year of action this time round, which I think is really good to see. As you say, it brings to life the threads that we've been talking about for a couple of years. And I think particularly if you go to Appendix 2, the board looks at Appendix 2 in the bundle, and the swim lanes across the quarters of the year, you know, that really clearly sets out for us the things which will start to happen as we go through the year. But assuming nothing blows us off course, you know, it starts to bring to life the journey that will take over the next 12 months. So I think it's really good stuff. Thank you.
No, I absolutely agree with that. Anybody else want to make any comments before we go to? Yes.
I think.
Shall we go for Kerry first?
No,
I think Vice Chair privilege.
I'll take it. I actually would like to endorse what's already been said. I thought the plan was really clear. What I really liked when I was reviewing this is I could see our evidence-based approach in it, and you know, I quite like an equality impact assessment. It's probably not everybody's favourite thing, but I could see the thread in that of, you know, for me, particularly around accessibility and, you know, the protected characteristics around frailty and older people. So I really welcome that. And it's already been said, but the ambition, I think, is really clear in this, but also our direction of travel, how we're going to get there. So for me, the third year on the board, it did feel quite different, and you can see the volume of work that's gone into it. So just one, hopefully very quick question is, you touched on it already, Jason, but in terms of our ambitions and our dependency on our system partners to deliver some of this. So obviously you were chatting to the chief execs earlier in the week, but is there anything you think it's helpful for us to be cited on at this point?
Well, I mean, I think we've got a bit of a journey to go on with the I guess with the new commissioning arrangements to see how they settle. What's I think increasingly clear is that the new JCC, you know, will continue to, talking about the EMS service only here, will continue to commission the once for Wales or one size fits all, you know, emergency 999 response service. I think what's becoming clear in our discussions, Rachel, is that there is a desire at a local level for health boards as commissioners to commission us as one of their providers, as a national provider on a local level, to help them respond to some of the local challenges they've got. You know, so it's very clear in most cases, in those conversations we've had, that there is a realization and acceptance, that we are more than just ambulances now. We're not just a transport organisation. We do other stuff, and we do it well, and increasingly we're doing more of that. And so those capabilities and the capacity we've got is increasingly recognised. So I think, Kerry, we'll start to see discussions develop through the year, where there will be a desire for us to partner, if you want to call it that, commission locally different types of service, or nuances to the service, beyond the one size fits all. Is that fair, Rachel, do you think?
Yeah, definitely.
Definitely.
I think we've different in each of the patches we've been to, but definitely a kind of sense of wanting to do more with us. And I think what hopefully you can see in the plan is there are things that we can do ourselves. So there are changes we can put into place which is in our gift, which will help the system. But actually, there'll still be an awful lot of patients that need those pathways, those different models of care within health boards that actually, as Jason said, I think there's an increasing, excitement about working with us differently into those pathways and creating different models, actually, really integrating our urgent care community response with their community teams in a way so that it's kind of seen as one community team that is supporting patients. So I think it's exciting. Yeah.
We shouldn't underestimate the scale of that change.
Yeah.
From what has been a perception of an ambulance service as a traditional kind of stretcher bearing bus service to something which is clinically led and clinically driven. I mean, that is a fantastic leap. If we can keep pushing on that, that's really good.
And I think you can, reflecting on conversations over the last 2 years, you can feel that. I think certainly in the East discussions, in the individual discussions with key players across the system. Yeah,
no, that's good. Paul.
Yeah, one question really is about the commissioner support. Were there any caveats to that support, or was it straightforward? Well, that's really good.
Unconditional.
That's really good. And the second thing, and we picked it up already, I think, is the confidence in WAST. I think that's been built over the last few years, and it's interesting how we mirror that against our reputational stuff that we're looking at. And it seems to me that the closer you get to health board senior level and have those discussions, because populations are different, the needs of different populations are clear across Wales, and within parts of Wales they're different as well. So that seems logical. I know we always push for a Once for Wales solution, but that doesn't work always. So I think that looking at the plan, I think it's an excellent plan because it shows ambition, but it also shows confidence. It's not something where you look at it and you think, yeah, that's a bit pie in the sky, we're not going to deliver that. I think we've got the ability to do that now, whereas a few years ago we probably didn't. We were writing a plan for someone else. This seems a plan for us as an organisation, so it's a really good plan, I think. And coming to the EQI, I thought that was really, it knits well. You can see the connections between the plan and the EQI as well, which is sometimes, again, you don't see that, it's disconnected, but and it tells the story that we've heard as a board over the last 12 months as well. So there's nothing in you think, well, where's that coming from? Yeah. So I think it's a very good plan, and I'm sure it'll be approved by Welsh Government as last year as well, so the year before. So good.
Well, is it going to be approved here, Paul? That's the first thing. I mean,
it's dodgy, cheers, dodgy.
I know, it is. It is. Any last minute, of course, reflections? I was just sitting there thinking the other thing that I suppose we was reflecting on is there's been a massive change in the leadership in the chief exec levels across the health boards. I know there's been a little bit of sort of moving the chess pieces, from Paris across to Betsy and things, but nevertheless, there's quite a lot of new faces, and also quite a lot of new faces around the chairs as well of the boards. Obviously at Betsy, but I mean there'll be a new one at Swansea Bay shortly, and the one at Paris hasn't been there that long, has he, and so on. So actually, compared to where it was maybe 2 or 3 years ago, it's probably a lot of new faces around, which is a good thing. So, shall we hold our breath and just look around the table and see, are we happy to approve the IMTP for onward circulation? Goodness me, it looks like you are okay, Rachel.
Lovely.
I haven't got to rush back and rewrite it in the next 24 hours.
So we will submit that now
later
today.
Absolutely.
So, thank you.
Good. All right. And well done. It's good. Really good document. Win-win. All righty. Let's move on. So I think we are on to finance, aren't we? Item 14, is that right? Yep. Item 14, revenue budget. So to you, Chris.
Thank you, Chair. Hopefully, a similar level of approval for this one to come, because it's a requirement of us from the statutory financial instructions, and my responsibilities within that to present to you as board a balanced budget for approval before the start of any financial year, which is what this paper seeks to do. It's deliberately framed as an initial revenue budget, again on the same context. It's dynamic. It's it's what we fixed at that point in time completely. It will evolve as we go through the year, but it does build on that within the IMTP, the financial plan, and the resource envelopes that we talked about within that plan. So there's an element of, as a standalone document from an auditable perspective, there's an element of repetition in some of the elements of this paper than what you've already seen certainly in the detailed annex or appendix 3 of the IMTP. But it does go into that little bit more, a slight sort of half a step level of detail below that in terms of what that means in terms of the resource envelope and how we will set those initial budgets from an income and expenditure perspective. The remaining elements, just to add to that within the paper, as I say, we met yesterday, so that's given us a basis now for that additional resource plan to support and enact the financial plan within the IMTP. But also gives us the basis on which there is an element you'll see in the appendix of budget at this stage of budgetedness held centrally and in reserves that will predominantly get devolved out through Q1, but it doesn't sort of preclude an approval of the budget in the first instance. And linked to that, as is the case in every previous year, myself and Jason will have dedicated budget meetings with each director through Q1 to formally sign off those resulting devolved budgets based on what's in this paper today, plus the iterations that will come following yesterday's conversation, the resource plan and the budget to follow, where the expenditure is going to hit to take the funding out of those central reserves into dedicated budgets through Q1. So this went to F&P as well last week, and it's brought today, Chair, if it's okay for the board to consider and approve, please, as F&P did recommend and endorsed the budget and recommended that the board does so.
Okay. Did you want to wear your jogger hat just for a few moments? If I can put it that way.
Not much more to add, really, other than to say the committee were very happy to endorse it and recommend for approval.
Good. So any questions? Yes, Paul.
Yeah, I just think it's interesting, is that I think Bethany's point, we are confident about the savings plan for this year because we did it last year, but we need to recognise that it's going to be tougher because it's on top of last year. It's not, you go back to basics and you start again. So I think perhaps that's difficult for the organisation to appreciate, that actually your baseline has changed and gone down by 6 million, and then you're asking another 6 million. So it's got its risks, and it's going to take a lot of hard work to get to that level again, because it's actually over 12 million in 2 years, which is different to 6 million. Do you know it gives you a different context.
Yeah, absolutely right, Paul.
So it's going to be a tough ask, I think.
And we recognise that very point at F&P as well.
Yeah,
Paul,
I
that it's
dialed
a
into
build
it.
on it's a build
Yeah.
effect.
Famous words, past performance, not always a guide to the future.
It's just tougher.
Yeah,
it's tougher.
It is. It is.
I guess I suppose that's why we talked about having to put that emphasis a little bit more on switch line emphasis, particularly, and building up to switching further of that on, hopefully through 24-25 on that switch to it not being necessarily about CIPs, cost improvements, alarms. There'll always be an element of that. There'll always be stuff that we'll be expected to do the same for more for the same or more for less, or however you want to describe it. But where we can switch as much of that as possible to opportunities through regeneration capacity, whatever, to offset those balances and plug those gaps, but also in a way that is more positive for the organisation and our staff and patients as well. Is the trick we're trying to take.
I think it's a good thing that the SRO is
couldn't agree more. Okay, so the ask is, are we prepared to approve it? All content to approve the revenue budget? Good, all right, thank you. So staying with you, Chris, for where we all are
For-
in terms of month 9 and it did a bit more, month 10 and 11.
Month 11. So yes, again, this brings to you the financial performance. So switching back to the current financial year and not losing the sight that there's a year end to land and deliver, and a set of accounts to draft over the next month, and a set of to be audited over the next few months. But so this brings the performance to month 11. It builds on a presentation again that was provided to F&P last week. Always slightly odd timing. We always have a board this time of the year. There's always 3 days of the financial year left, and so much real opportunity there is to influence anything from
That's
today
right.
is
Yeah,
limited,
right.
to say the least. Fortunately, we're not in a position of having to necessarily influence anything. We just, so I take the paper as read. Just to update, there's no significant changes in terms that I'm aware of as we've gone through March. In terms of that, which we're expected therefore to land as a next week, literally next week, as an initial month 12 position and a draft year end position. The only thing I would just flag, and because we did, I did take a few more minutes than I probably do normally on this at F&P as well, was on the capital position, because it does get quite stark at this time of the year when you see what the annual capital plan is at the end of February and how much you've actually spent at the end of February and what has to happen through March, which is always a challenge. But just to provide a further updated assurance to board, over 95% of that we've needed to enact through March, if you like, either in the context of actually receipting goods, paying invoices for an element of the plan that was described in the committee as the reason why March catches up, if you like, in some ways with some items, and it's pulled out in the paper in paragraph 18 of some of the things that have had to sort of, and it's been exacerbated a little bit this year about some of the phasing and profile and timing of the new CAS system as well, landed in the last quarter, which has made that sort of variation in March even greater. But yeah, over 90%, 95% of that has been already delivered. There is still an element of final fine-tuning, as there always will be, right up to, and I have to say, at least I couldn't have fallen at a worse time from me and my teams this year, because the team will be working over the weekend to do that, to ensure that we land the capital position in particular, because it does, there's a nuance and a technical relationship to the cash position is in the back. It's in our cash book, literally on the 31st of March. So the work will continue over the weekend on that. So I just want to add note my thanks particularly to Ed Roberts and a couple of his team who will be working certainly tomorrow and probably on the weekend as well to nail that for us. And it's a real tight balance we try to land into to literally within the nearest £1,000 on the capital expenditure limit. So just to add that, but happy to take questions. Issue for noted.
Yeah, no, absolutely. But any questions or comments? No, good. Okay, so we note that, we note the capital programme, and we note the submission document that was contained in the papers. So all good. All right, item 16 then. Angela, you.
Thank you, Chair. I think we've got 2 or 3 slides, if that's okay, if you'll bear with me. And the only reason for a few slides is just to show the progress and the journey in relation to the development of the strategic equality plan. And if as Hannah is our equality and diversity led champion, I'm hoping Hannah, after I've done this short presentation, if you'd like to come in, if that's okay. So just I can do the first slide. Thank you. Thank you. Obviously, the rich picture. We have to obviously reiterate the fact that this document, albeit it is required under the public sector equality duty, we would want to do it anyway, because obviously it is about demonstrating not only internally but externally the commitment we give to equality, diversity and inclusion. Next slide, thanks. So I just wanted to show you how this has developed and progressed to get us to the point today where hopefully you'll endorse and allow us to publish it. So last year, so obviously over the last 9 months, we've had a review of the previous strategic equality plan. We have looked at our progress against those, and obviously the drafting of this has happened over a 8-month period. We did extensive consultation and engagement with local community groups, our stakeholders internally, and that's allowed us to really take that rich insight and information and shape something that hopefully will resonate with a wide range of stakeholders. We had workshops with a number of the non-execs, also with our staff networks and with directorate leads. And obviously there was the significant public consultation to get us to the point today. Thank you. Obviously, before this, it's gone to the People and Culture Committee, and we did some more socialising, discussion, feedback. So it's been quite dynamic in terms of responding to that feedback in the last 3 or 4 weeks, making some changes, and also giving reassurance to People and Culture Committee in terms of the rigour and the governance around making sure that we can deliver this, because it's not just about having a document, it's about, you know, the realism and the achievability of what we are delivering. So in particular, we took into account the direct feedback we had in terms of making sure there was more clarity around the measures of success. We also really enhanced the focus around our exec and our NEDs in terms of leading by example. And of course, we met with Hannah directly again, just to make sure that she was giving us the lens of that champion as well, to ensure that it really did feel that it was a well-rounded document. Thank you. I just want to then give you some reassurance in terms of implementation, because you'll note in the paper we talk about some of the, and I suppose I would call them risks. It's around making sure that we really do make sure that this is delivered. And that's the operationalizing of this document. So we do have an ED&I steering group. They will play a key role in making sure that this is delivered at that local level, and each of those members will report back to their directorate groups to ensure that this is getting the visibility that it needs. And they'll also be identifying barriers and support they need, and that will be coming back through the governance chains and potentially into People and Culture, and through myself and Hannah in terms of that champion role. As I said, the non-exec in our People and Culture Committee roles is to make sure that you're monitoring and progress, and that we are giving you assurance, and that we are giving the board assurance in terms of progress. Similarly, to make sure that we're promoting EDI and ensuring it's embedded. And I think from the conversations we've had this morning, particularly in relation right the way through in terms of the themes, but particularly the IMTP, I think that comes through loud and clear. So that's really positive. And again, from a non-exec perspective, it's about using those experiences that you gain in other organisations, other experiences, to keep shaping and influencing and providing your insight to ensure that we are listening to the communities that we serve. And then finally, from a trust board role consideration, it's to make sure that we are promoting the ED&I agenda and ensure it's embedded throughout all of our activities. And of course, then the role modelling, particularly when we are doing our visits, when we are representing the organisation, and when we're engaging with our stakeholders. So that's just to give you that level of reassurance. Hannah, did you want to come in at this point? Because you might want to just add something.
Sure, thanks, Angie. And I suppose the first thing is just to record my thanks, as kind of ED&I champion, to you, to Catherine, and to Kat for all of the work that's gone into this. As you alluded to, we've worked quite closely together on this. I know we had various ideas and suggestions at the People and Culture Committee, and I've talked all of those through with Catherine. One of the things that I suppose I would just like to point out is that as we often find with these kinds of documents, this is our strategic equality plan. It's our overview, you know, for the next few years, but there will be a much more detailed action plan that sits underneath that, so that we can track really specifically the improvements that we're making, what's working, what we need to put a little bit of extra time or focus into as time goes on. It's great to see the common thread of kind of equality and diversity running through the different documents that we've discussed today. And I suppose the key thing is that we make sure that this is always very present in the room to us as well. And so I'm looking forward to us continuing to work together to build on the progress that we've made. And I hope to continue to be brave in challenging each other on the areas where we're not yet where we want to be. And that's uncomfortable. But I think, you know, as leaders, as people who have the privilege of sitting around this table, it is our job to lead by example, to be willing to be made uncomfortable when we perhaps notice that we're not perhaps doing things exactly as we ought, or language has changed and we haven't sort of cottoned on. So I think yeah, looking forward to working all together, and I have a lot of confidence in the potential of this board to really drive that work and hopefully encourage and model the huge value that we place on this to our colleagues across the organisation. So thanks very much, Andy. Thanks very much, Angie.
You're welcome.
Easily confused, very.
I'm
going to have sort of ongoing contact with Catherine and Kat probably every couple of months to keep a close eye on how this develops as the EDI champion. So thank you.
Thank you.
Thank you, Hannah.
Thank you.
So open to questions?
Yep, questions and
comments?
hopefully endorsements, so we
And
can
of course,
publish it
we are asked to approve it.
ASAP.
Indeed. Yes.
Very, very happy to endorse it. I think the process of getting us here has been really valuable, actually, and I think that people have been listened to and heard, and it's an honest and ambitious plan. And the question for me is just around, probably relates more to the action plan. So, you know, for me, this plan is brilliant, isn't it? But what does good look like? And well, when we know, and we're always going to have a plan, because sadly we're not going to tackle this in a year, probably 5. So for me, it's then what we're doing across directorates, and that this doesn't sit in one particular directorate, it's everybody's business. So how do we know that those directorates are doing well, or how we identify areas of focus?
Yeah, and so through the governance of our Equality, Diversity, Inclusion Steering Group, we will get that feedback because we have directorate leads. Similarly, in our local directorate plans, that theme of equality and inclusion is there. So again, I would expect in directorate plans that we'll see that coming through, particularly under the umbrella of culture, because actually it encompasses that work as well. And similarly, in the people and culture plan more generally, there are direct actions that link to this, because what I'm trying to avoid is numerous action plans that suggest we're doing lots of different activities. Actually, they come under the same umbrella, but we will clearly reference which one of the under this strategic equality plan, what they're addressing, Kerry. But again, I would expect the governance route as well to be through People and Culture Committee, that we will regularly see that progress being made against the the overarching objectives, but also in relation to what's happening in each part of the organisation.
I'm not going to take any credit for this whatsoever, despite Hannah's kind words, but I absolutely welcome this. I mean, from our profession, you know, we know there's been a great deal in terms of progress around that gender imbalance that there's been in previous years. You know, from when I started, it was a largely male profession. It's very quickly moved, quickly, you'd argue, but nevertheless, you go on a pre-reg program now, and it's predominantly females, and so you've seen that real switch on things. Yet we still see a massive imbalance in terms of ethnicity. So for us as a lead employer, I think to be taking real active steps in terms of addressing some of that imbalance that we have in our ethnicity. Fabulous work. Happy to support.
And just to say, obviously, Andy plays a key role in terms of linking with the universities we work with. And I know today we've done it collectively, but I know you do it constantly about challenging recruitment processes in our universities that we have relationships with, but also really trying to promote the organisation as an employer of choice. So thank you, Andy.
Yeah, it's just from a governance point of view, yes, the plan came to PCC, we endorsed it. There were some further questions that Hannah's gone through, particularly around the action plan, and we'll know that there'll be an annual delivery plan with those actions in. I think what you will see as we go through this, which we did at PCC, there's a number of statutory plans we have to submit, but actually they all come together as part of our People and Culture plan. And it's so whilst we have the anti-racist plan we talk about, and we'll talk about the annual workforce equality and gender pay gap plan report, they're all the same, and it's about changing the culture, not just about delivering these plans. So it'll be interesting as we work through the annual plan how they all link together, and that's quite a task, I think, when we go to PCC, is how does the anti-racist plan and the equality plan and the workforce equality monitoring report and all these come together, and how do we see it as a whole rather than individual plans, which is the challenge for us, isn't it? And if it's a challenge for us, it's going to be a challenge for our leaders in all parts of WAST as well, and our staff. So I think we've got to try and simplify a lot of these messages, because actually it is about how we behave, how we react, and our culture within the organisation. And these plans are just something we have to submit to someone, but it's much more than that, I think, in terms of us as an organisation, and that's hard to understand, isn't it, and pull together.
And I think, therefore, Paul, that point around how we communicate, but also that emphasis we're putting around safety, because if we can create a feeling of safety within the workplace, people feel that they trust the organisation, it will indirectly help with quite a range of issues, particularly around turnover, but more importantly about recruitment.
Yeah.
Because then if this is an organisation that recognise that if you come here, you'll be valued, you'll be trusted, you'll feel safe, that will help. So that link, I really want to make sure people can see the link, and these aren't seen as initiatives that we're doing, that it's all linked back to what we're trying to achieve.
And I think that particularly with EDI, we've got to recognise it's just cats, really, isn't it? And there's not a lot of resource available to us as an organisation to take these things forward. So
yeah, and that point about the capacity, that therefore I'm hoping we're going to we've now got obviously a retention role as well, so that links into this, the guardian role. These are all roles that fit under that same umbrella. So rather than it feeling like it's just one person, it needs to feel that, and also the director at Leeds will play a key role as well.
Yeah.
Okay. Have we lost Hannah, by the way? Is she?
The connection to the television.
I think I'm still here.
She's here.
You're still here.
You can't see me.
No, as long as you're still there, that's grand. If we can't see you, so if you need to come in, just holler out, Hannah, and we'll stop and listen.
Thank you.
You can see your hand. Okay, Grubby, you can let us know then. That's perfect. Okay. So Estelle, your hand up.
Thanks, Chair. It was just that point, sort of reiteration of that point I made earlier, really, about change readiness and culturally change ready, that we have a workforce who are receptive to a broader base of people coming through, and that we are welcoming. So, if you're a new starter, regardless of, what you do, where you join us, do you feel that you are welcomed? Do you feel you are supported? Do you feel that people are friendly? All those things are going to have a bearing, and they're going to help us with some of the EDI stuff. Because I take your point, Paul, we've got loads of plans. And I think for a lot of our workforce, they go, oh, here we go, a blooming plan. What the hell is all this about again? It's connecting, joining the dots for people, and making it clear that, we all have a responsibility. There's not just a plan that Kat or somebody else is monitoring somewhere and we've got to do X, Y, Z. It's when we have a new starter in our team, how do we support them? How do we welcome them? How, what sort of, informal conversations do we have, so that people feel, oh, this is a place I want to stay. These people are interested in me, not just interested in what I do. They're interested in me, and I think that's really important. And when we have people with perhaps different backgrounds, different religions, whatever it is, people feel perhaps a bit anxious about that. And I think we just need to support staff to bring their confidence up to welcome everybody.
Good, thanks so much. Okay, just last point then.
Just very quickly, thank you, Chair. Completely agree with all the positive comments made. If I can show you in the break, Ange, there is a typo in the Welsh translation document.
I've seen one in the other.
Okay, in the Welsh one, on page 5.
Yeah, thank you.
Okay, so I'll be asked to approve it so it can be published. Just checking everybody's consent to do that. We are, so go ahead, Angie, publish.
Oh, do you know, communications are going to be so busy today. They really are.
It's Easter,
And we're still with you.
Yes,
This
we are.
time for equality monitoring, gender pay gap.
Yes, so again, thank you very much for committing to time on this today. Again, relates to our statutory requirements under the Equality Act to publish information around our gender pay gap, but also in relation to our workforce equality monitoring. Just in terms of this, obviously this is last year, so 22-23. So I just want to make that point. And what we did in People and Culture Committee obviously was to go through this, but it was also to look forward. We really did focus on how far we've come since this actual data and what we've been doing in terms of initiatives. But I suppose a couple of things I'd just like to pull out. Whilst our gender pay gap has remained relatively static, and that it's good that it hasn't decreased, I will flag my concern about the fact that it hasn't improved either. So I'm not sitting here thinking we should be complacent. There is significant work we need to do around this. But I do feel reassured. The work we've been doing, particularly around flexible working, barriers to progression, barriers to pursuing opportunities directly relates to our female workforce, coupled with the work we've been doing around carers leave, the implementation of the Carers Act next month will make a difference. So the work that has been going on in terms of people and culture directly impacts on our female workforce. So that is positive, but there is still much more we can do. And again, that work around our leadership development programs, the support we're giving colleagues, the reverse mentoring that we're doing as part of our Voices network, all of these things I hope will make a direct positive contribution to what we see going forward. But this is historic, so I have to share with you that obviously, albeit it's a gender pay gap of 5.4, and that does compare reasonably favourably across NHS Wales. In terms of other ambulance trusts, there are quite a few who are better than us, so we are trying to learn as well from them in terms of how they have implemented different initiatives. So I don't want you to think that we are just sitting here thinking this is okay. So that was my first point on the gender pay gap. So don't know if there's any other questions on that.
Anybody? No, doesn't look like it. Nope.
So if we're happy,
Yep.
we will obviously,
Yep.
if we're happy afterwards, we can
Good, yeah.
endorse and publish.
Mhm.
And then the workforce equality monitoring, again, a year behind. This one is, and I think, Andy, you mentioned it in terms of my particular concerns in terms of the very small numbers of staff we have within the Black, Asian and minority ethnic background. Albeit there's been a slight improvement, it is just not in the sort of levels that we would want to see. And that's why we've been doing such active work with the student population, with the universities, with HEIW. We've also connected with the Equalities Commission to put them in touch with the universities as well, because obviously that pipeline of diverse talent would help us, and actually we aren't seeing that diversity in the students at the moment. And we do know that the universities have huge numbers of applicants, we know that, but it's just not translating into the newly qualifieds that are coming out the other end at the moment. So it's a massive issue for us. But we continue to think of ways in which we can again focus on that safety, trust, and the commitment to do more work around inclusive recruitment. So we will be running an inclusive recruitment conference this year, again, trying to really promote the type of organisation we are and why people should come and work with us. But there is much more to do. But on that point, happy to take any questions on the workforce monitoring.
Okay, so again, questions on, doesn't look like it. Oh, yes. Sorry.
On the monitoring, and I think in this report, I'm sorry I can't find it now, I read something about the limitations on some of the data.
Yeah.
Could you say a little bit more about that, and are we able to do some work to improve that?
So because this is the electronic systems record, ESR, the system that is a national system, the limitations are around how people can identify themselves in terms of their gender, and there is also limitations in terms of reporting. We have fed back in some of our concerns about that, and with the implementation of a new electronic system in 2024-25, first stage, things will improve. But at the moment, we are limited by it. What we have been doing, though, locally, is to try to work to provide additional routes for colleagues who potentially wish to identify in a way that suits them. But it is difficult at the moment because of those limitations. And that is across the NHS in Wales. So it's a challenge. It is a significant challenge.
It's surprising, isn't it, for such a huge employer that we've got that challenge. So hopefully in 2024-25 we'll
It's the initial implementation.
And it doesn't include our bank staff either, does it?
Not on gender, but not on this one. So there are some gaps, and we know that, which is why rather than we do focus on the stats, of course, but it's more about actually what we're hearing from staff. Are they feeling that they're able to identify in the way that they wish? The other thing I should mention is about declaration rates as well. This has been a key focus of people and culture. Our declaration rates could be better. Individuals' desire to share with us those protected characteristics is not as good as it should be. Again, this can relate to trust and how people feel safe. So it is an area that the Equality Diversity Steering Group will be looking at, and the Directorate leads, because we're actively encouraging people to obviously fill in the data. But there is much more to do there.
Okay, Chair, just one other quick question. So on the disability, on page 2, where you've got the key issues implications, we talk about the disability rate in Wales being 21.1%. That's census data. I'm wondering why we're not using a working age number in there. Do we need to use the census data? Because it's a difficult comparison, isn't it? Because a lot of those people, I used to know this, I'm sorry, I don't anymore, but so if the rate is 12%, it's quite different to 21, isn't it? So I'm just wondering, is there a way in which we can get a more accurate comparison in there for future reports?
I'll check. I don't know if that was just a core requirement that we're expected to use, but I will check.
Okay.
Because like you, I would agree that would be a much better reference point, and more powerful. I'll take that as an action if that's okay.
Thank you, Chair. I just wanted to ask again around the Welsh translation document, Angie, and I'm wondering if it's deliberate. So there are several words in the Welsh translation document on 17.2a where they are all in English. They're all connected to the icons we use, you know?
Yeah.
So when we talk about take ownership, broaden our understanding, etc. So on page 1 and page 4, they are all written in English, and I find that strange for so many English words, I guess, to be in a Welsh document. I think that could cause some feedback if we publish it in this format, because across the bottom of page 1 and then the diagram again at the bottom of page 4, it's completely in English. Yes.
Welsh translations of those.
Yeah, but they're all in English in this document. And again, in document 17.1a, which is the translation for the gender pay gap, there are errors there as well. One error is around all the icons being in English, but there is also a word that's just an English word in large in bold. So I can show you that afterwards if you
Would you
want.
please? Yeah, because it's not acceptable. So apologies for that.
So it's important before it's published.
Yes,
isn't it?
absolutely. Yeah, I'll take those. Absolutely. We'll do that. Is that okay if we do that at the?
Yeah, of course.
Thanks for that.
Good, well spotted, Bethan, thank you. So we're asked to approve the gender pay gap report and approve the workforce equality monitoring report. Everybody content with those approvals? There we are. Good. Okay. Trish, over to you. Governance report.
Thanks, Chair. This is really just for noting 2 sections. The first is our use of the trust seal. There's been no chair's actions to ratify. So just noting the use of the trust seal, and then noting 3 decisions made in closed session since November. We're required under our standing orders to bring those back into public when we're able to, and it also aligns with our duty of transparency. So they're just for noting, Chair.
Fine. Okay, so we duly note those. Looking around to make sure there were no intrusive questions. No. Good. Okay, so we move on to the last few sections, really. That's committee reports. Bethan, Quest.
Okay, thank you, Chair. So we met on the 8th of February. As always, our agenda was full of items related to risks 2 to 3 and 2 to 4, as you referred to earlier. Under the alert section, we talked in detail, as always, around the system pressures and some of the highlights, you know, or lowlights, depending which way you look at it. 27,000 hours lost to handover delays in January. It was interesting because the patient story that we received, which I'll come on to in a second, highlighted the impact of those handover delays, really. You know, 1,880 patients waited over 12 hours in Q3, 1 patient waited over 45 hours, so quite stark data there. So as Trish mentioned earlier, talking about the risk reports, whilst the scores for risk 2 to 3 and 2 to 4, the rating hasn't changed, you know, it was very clear to us as committee that there's been continuous review and monitoring and work undertaken and improvements wherever possible. Members may recall that the Quest Committee previously raised an alert around the effect on the PTR and operational quality teams in terms of the volume and breadth of complaints, etc., that were being received. And I think it's important to highlight that that pressure is continuing. However, the committee did receive some assurance insofar as there's good progress being made on appointing to the roles, and these roles will drive the improvement plan in the future. However, the committee will continue to monitor progress moving forward. We did take Chair's action between meetings, and that was to approve the infection prevention and control policy, and the committee did ratify this at our meeting. As always now moving forwards, we are focusing on clinical indicators, and the indicator that we looked at in this meeting was a deep dive on stroke. And helpfully attached to that, we received the HIW Stroke Pathways report and also the clinical audit plan to further substantiate some of that conversation. In the advice section, I'll come on to the patient's story now. So we heard from Alison Cassidy, whose daughter Emma, who has a learning disability. Emma needed very urgent dental care, and it was clear that that dental care couldn't be provided without anaesthesia, so she needed to be supported into hospital. There were significant system pressures on that day, and the impact of that was really alarming on Emma, really, given her disabilities anyway. After 28 hours, a learning disability liaison nurse visited and sedated Emma in her garden, and then a taxi was booked to take Emma to the hospital for her to start to have her treatment. Understandably, the committee were really shocked to hear this. Throughout the wait, because of some of the challenges Emma experiences in her day-to-day life, she became very distressed, which was really difficult for us to hear as a committee. However, importantly, I think, Alison and Emma's story is being shared at Betsy Cadwallader as well, specifically in their organisational learning forum, so we were pleased to hear that. We discussed our quality strategy, and whilst it's fair to say that some areas of progress have been slower than we would have liked, the committee did recognise there's been an awful lot of work undertaken with regards to progress in the quality strategy. And of course, the newly appointed quality leads now have a pivotal role to continue to take this forward in the future. We received the HIW annual report, which is also attached in today's papers, and they highlight the ongoing system pressures. They talked about safeguarding, both discussions we have frequently and continually at Quest. We approved our data protection policy. It was Paul's last meeting of Quest. And it's fair to say that we had a conversation, really, both myself and committee members and other officers who attend thanked Paul for his commitment, specifically to the Quest committee on this occasion, because he has consistently championed patient safety, the experience of patients, and the matters of quality generally. So thank you, Paul, for all that you've done for Quest. Moving forward to the assure section then, we had a meds management assurance report, and this is the first of its kind. So I think that's important to say that at the outset. And what we could see from receiving this is that the previous internal audit on meds management has been a good lever for change. So we've seen progress in that area. We've talked about the MIQPR earlier, so I won't go into that any further. We received a Q3 update on the clinical audit plan, and thankfully there were no escalations, so that was positive. We approved the clinical audit planning for 24-25. So again, that gives us a framework for moving forward for the next year at Quest as well in terms of reporting. We had KPI report on information security and governance, and that was noted. And in looking at the audit tracker, we could see that 12% of the Quest-related actions were closed in quarter. So again, good progress being made. As with all other committees, we had our annual effectiveness review, we had documentations related to that, along with the draft annual report and the amended terms of reference. And then finally, we had a paper specifically on our risks 223, 224, which we discussed throughout the meeting. Importantly, and my final point, I suppose, is there's a new risk being developed on information governance and information security. So at that point, Chair, I'm happy to stop and take any questions or comments.
Good. Thank you very much, Bethan. All okay with that? Anybody want to do a question on that? So, Paul, I think next, quick summary on people and culture.
The last PCC, we broadened the invite to other board members because we actually focused on equality, diversity and inclusion, and all the reports, etc., have been through the board already. So I won't comment on them. I'll take us to the staff story, if I may. And we had a gentleman, Darren Anthony, who's currently in ENT2, and he was inspiring, I have to say, in terms of his journey. He had tried to get into WAST about 13 years ago, but for a variety of reasons wasn't able to. And then he joined us under apprenticeship scheme, and he was actually he won the Skills for Health Apprentice of the Year award. And his enthusiasm, his commitment, his perseverance, but also the support that the organisation had given to him and the opportunity that he had that he never thought he would have. So he was really very explicit about the organisation, but also about the rewards that he was gaining through the support he was having. And he's now applying for paramedic training as well. So he was incredible, and we wanted that to be spread far and wide. Really, it was palpable how he thanked the organisation for the opportunity he thought he would never have, and it was really inspiring. We had the draft health and wellbeing plan presented to the committee for 2025 to 2029. We received that for comments. We gave a number of comments, but one of the things that we were talking about is how do we make sure that that plan is understandable at all levels within the organisation? How do we make it more simple, more focused? And obviously that will continue to work through now to the next PCC meeting. We had our annual effectiveness review that Trish took us through. What should you say about the annual effectiveness review? I think it was the participation was slightly less than previously. We did talk about the length of the review and some of the items within that review and whether that needs to change a little. There was very little change to the terms of reference for the committee, but a recognition that there was, like WAST, it's a very difficult committee in terms of its agenda size. And a lot of the negative elements was around how long it takes and the amount of paperwork, etc. But we felt, because of the breadth of the committee, and recognising that 4 years ago, 5 years ago, we didn't have this committee. It's just interesting that it's a very big committee agenda. So we agreed the terms of reference changes, but there was very little else, I think, Trish. We approved 2 policies, the All Wales policy for flexible working and the home working policy for WAST, so we approved them. We discussed the People and Culture Plan metrics. They were presented, and also the IMTP plan, and we commended those for inclusion into the IMTP and for further assurance at the committee. On the MIQPR, one of the questions we raised was about Charo and the utilisation of Charo, and we've asked that Quest have a look at that. And I know, Andy, you've been doing some work on that anyway, but we felt that we need some further assurance and understanding of the work of Charo. And I noticed in Jason's report that you had spent some time looking at the what Charo was asked to attend, etc. So that we brought that up and thought that Quest would be a useful way of looking deeper into that issue. We then had the WAST highlight report. And again, we've said, I think, Andrew, that we will have a more detailed report in your report going forward at PCC. So rather than just get the highlight report from WASP, that we actually have some narrative within Angie's reports. But it was good to see that there's been a lot of discussion and I think good joint working. So we agreed that that risk level should drop, should reflect that change in the relationship between ourselves and our trade union partners, and that was good to see. And then in the private session, we reviewed the progress on 4 suspensions over 4 months. Obviously, it's confidential, but we understood the reasons for that. And there are 2 cases lodged with the Employment Tribunal, which has decreased. And again, that will be continued to be considered at the closed session of the PCC. The audit tracker was reviewed, and we noted good progress in closing off items, which is always good to see. And there was regional assurance on the retention of staff, internal audit, and the good progress being made on the moving on interview process, although that wasn't fully embedded during the time of the audit. The auditors recognised that was taking us forward. And then we looked at the committee's cycle of business, which is on track, and there was no escalations. In terms of the risks, we've already discussed the issue about high absence rates, and that is continuing to be a problem for us in terms of how we improve on that area. But we looked again at the assurances and the controls, and there were a number of mitigating actions that we knew, which we saw in the BAF, and we felt that those were appropriate, and hopefully will see us make a move forward, recognising the feedback we've had from the staff survey, for example. And then on the damage to the trust reputation, we continued the score at that level of 20, but we felt there should be a deeper dive, and that will go to the May PCC. So there'll be a deeper dive on the trust reputation. It's interesting to hear Jason and Rachel's reflections and the discussions having with the chief executive, etc. So we need to bring that into that conversation. It's quite easy otherwise to take a quite negative view. We've already talked about the trade union partnerships was good. And the risk 555, the deterioration of staff health remains unchanged. We continue that score at 15. And we discussed the staff aspects of risk 223 and 224, which obviously have a significant impact on our workforce. There were no new risks identified at that meeting, and it was my last meeting, so I thank the committee for its forbearance, for my chairing, and I had some nice words said about me, so thank you very much.
Thank you both. Kerry.
Okay, so I'm providing this on behalf of Peter. So in the alert section on the audit for the vehicle replacement programme, the internal audit, there was an issue of compliance with the standing orders raised, and the committee sought assurance on what's going to be happening next. And Trish is doing some work behind the scenes, and Trish is happy to say a little bit more about that if that's helpful at this stage.
Yeah. Thanks, Kerry. So I think this was very specifically on the application of the requirement for the approval of individual contracts by the board in the scheme of reservation. So those things that are reserved to the board. And I think it's important to note that for this vehicle replacement program, the board had seen the business case, had seen the procurement values. It was a specific issue of the individual contract approvals. But this was wider than this vehicle replacement program. It's actually about the general application of that section, and it was helpful to have that drawn out from this. And I think it's important to note that this was the only limited assurance finding in an otherwise reasonable assurance audit. But it's also led us to a place where we're able to develop a governance practice note to plug that gap and to give some clarity, not just on that, but on other areas of pathways to board approval. And we'll bring that to the April audit committee. And we've had some really good engagement from Audit Wales and internal audit, as well as Peter as the audit chair, to really make sure that that's going to work for the organisation as well.
Yep.
Okay. So then in the advice section, we looked at the 24-25 internal audit plan, and that was approved. The list is in the AAA report. And then just on the assure section, I wanted to draw attention to the policies. So there's been a lot of work going on behind the scenes in terms of reviewing those policies that had passed their date. So, and actually Audit Committee took assurance that we were absolutely on track with that. And then the other point I wanted to mention was just on the structured assessment. So Fleur obviously presented that. So I think that's about it, unless there are any specific questions, which I may need to defer to others.
Okay. Doesn't look like it. Nothing on the screen. No. Okay. Whilst you're on a roll, Kerry, do you want to just carry? I think you're also going to just cover the Finance and Performance Committee.
Oh, well, I wasn't there actually,
Ah.
so hopefully not.
Okay, that's all right then. Oh, Bethan, my apologies. I can't read, can I?
Thank you,
Sorry,
Chair.
Bethan.
So we met very recently on the 19th of March. Several of the items we've already covered today, so I won't mention them again. The committee were assured the work was ongoing with regards to the strategic demand and capacity review. So that was positive. I know Peter's not here with us today, but it was Peter Curran's first meeting. Under the assurance section, we discussed the financial sustainability programme, and we recognised that we'd had gross savings of just over 6 million achieved against a target of just over 5.4 million. So we've overachieved. We did at this point recognise there is a challenge of finding cumulative costs year on year, so it's only going to get more difficult. We celebrated the response from across WAST really, in terms of all directorates, all officers working hard to achieve the efficiencies that we did. For next year, we agreed that there would be more work on the income generation and commercialisation aspect. We felt this would be critical to take this to the next level moving forward. We received a report on our digital KPIs. They were reported to us and reviewed by exception. We had an agenda item around value-based healthcare, and we received an update of the activities from the working group looking at value-based healthcare. We had an interesting conversation to waste legislation, and we can see there's been an awful lot of work in this area, but importantly, some of the changes actually could result in civil action for any areas of non-compliance. So really, really important that we do grab this, and we could see that officers have, so that was great. As with other committees, we had our annual effectiveness review feedback. We received the annual report, and that is going to be reviewed by the Audit Committee in its meeting next month. We received 4 internal audit reports. The first one on decarbonisation, where we had a limited assurance. But it's important to say that this was conducted across all NHS Wales bodies, and all received a limited assurance. And central to a lot of this were the financial challenges really that inhibit some areas of progression. We had an internal audit report on vehicle replacement programme, which received a reasonable assurance. One on strategy development, again, receiving a reasonable assurance. And finally, on ICT contract management, again, receiving reasonable assurance. With regards to the risks and the conversation that we had, there were no material changes to the 8 principal risks that the Finance and Performance Committee considers. All the scores remain static. So again, I'll stop at that point. I'm happy for comments or questions.
Doesn't look like anybody waving at me. Fine. The last one is about Remuneration Committee. That did meet. I think it was fairly routine matters in terms of job rebandings and change of title for Trish and a few other administrative factors, wasn't it? From memory. Okay. Right. We move on to consent items. Those are all taken as read, I think, aren't they? Various minutes. Committee reporting. So that takes us to closing items. Paul.
I'm a closing item.
Yeah. And the really good news, Paul, is that we're scheduled to go on till 1:30, so we've got 40 minutes to talk about you.
We've got lots of things we could say.
There are. I think most of those will leave the private section though, given that this is the public session, so we'll have to contain ourselves to well, from my point of view, a really serious, vote of thanks, Paul, for your contribution since I've been here. But Jason, do you want to say a few words? Because my time here is limited to, well, it feels like forever, but it isn't that long. You've been here a lot longer than I have. And
Paul's been here longer than I have, but none of us have been here as long as Paul has in the NHS. So Paul started his career in the NHS in Wales nearly 50 years ago. 49 years and X amount of days, I'm sure you're counting. You began as a nurse, didn't you? And went on to education, went on to nurse tutoring, and you were recounting a story of catching up very recently with 20 odd of your students, some 40 years later, weren't you? Many of whom are still here in Wales, not many are still working in the NHS. After that, you went on to work in a range of general management roles, and also after which you first became a chief exec in the NHS in what was North Glamorgan in 2005, there or thereabouts. There or thereabouts, and then went on to take over the reins in Cardiff and Vale for a while before retiring and joining us, 8 years ago. You'd worked, as we said, in North Glamorgan, in CTM, Cardiff and Vale, and also internationally in South Africa, where you were part of a team setting up healthcare facilities in a town in South Africa. All of which, of course, over 50 years, Paul, you will have positively touched the lives of thousands of staff and thousands of patients. And of course, more recently, you've been one yourself. And I just want to perhaps thank you for your courage and bravery in your public story about your own diagnosis and your journey with cancer recently, which is clearly good news and positive for you, which is really good. So on a personal note, thank you for your support to me over the last 5.5 years since I joined the team, and to the organisation over the last 8 years. But more importantly, I think over the 5 decades that you've been in public service here in Wales. You probably won't know it, but there are thousands of people that you would have positively touched, each and every one of them grateful for everything you've done. So thank you.
Thank you very much.
So on that note, we're going to hand the microphone in. Paul, you've got 35 minutes.
Thank you, Jason. Thanks for everyone. I've had some lovely messages, and yeah, it's been great. It's been a great experience working in WAST. I always said when I came to WAST that I'd been in the health service 40 years and hadn't thought about an ambulance service at all. They just brought me patients to health boards that I didn't want. And you know, it all happened down there, and so coming into WAST, you learn a huge amount. And one of the things that I think people should do is rotate through some of these services just to understand what it's like to be on the other side. And that's the same for WAST people going into health boards, I mean, across the system, because we don't see it as a system. However long you've been working, you see that narrow bit, you know, whether that was when I was a nurse and you had your ward, or whether that, you know, nurse and officer, you had 3 wards or 4 wards. You just look at that little compartment. So it's quite difficult then to see across the system. WAST has changed enormously. I couldn't tell you. I can remember I retired in the February of 2015, and Tracy Myhill was the chief executive, and WAST did not have a plan for 1 year, not one plan, what we was going to do. So Tracy said, will you come and do a 1-year plan? And looking at and that's why the IMTP to me is such a huge, huge change, because I spent probably about 3 months developing a 1-year plan for WAST at that time, which was because Welsh Government were writing off WAST. They were going to actually take it apart, and they were going to devolve it to the health boards. And Tracy didn't want that, and I don't think anyone wanted that. So we said, right, let's do this 1-year plan. So I wrote this 1-year plan, and it was very little consultation. Nobody was interested. It was feeding the beast, but it got us to the next year. So when you look at the IMTP now, it is, you know, world away from where we were. And also this board is, I think, the discussions we have at this board, I think, are so different to, again, when we first came. It was very transactional. It was all about targets. It was all about, well, you know, you've got to hit this target, hit that target. And I was saying to Angie, you know, we didn't have a people and culture committee. It was in F&P. So anything to talk about the workforce, it was about sickness, it was about absence, it was about turnover. It was very transactional. So again, to see that committee develop and flourish, and the reports that come to the board is just hugely satisfying, because we never had that. And I think, and I know you've just done, it'd be interesting to see what your executive feedback is on your 360, but from a personal point of view, I think you're a very, very good executive team. And I think the board should be very, very encouraged and trusting of that executive team, because you're very good. And I've worked with a large number of them. What I like about the exec team is you challenge each other, you come with different views, and you're not afraid to say it. And I've witnessed that, and very often you don't see that. And you might have it in the room upstairs, but you actually do talk about things differently, and you disagree with each other in board committees and board meetings. And I think that's really healthy. That's a good thing. It's not a bad thing. So I've been very fortunate to join WAST at the time I did, but I'm fortunate to leave it in the position that it is, because I think it's in a very strong position. And when I said earlier, there was no confidence in WAST, and you just look at the conversations you're having now and people talking about WAST and you having an influence, that is a huge step forward. And it'll continue. I'm quite sure it will continue. And not only locally, we're part of ACE. We were sort of that little Welsh group that came along. But now we're actually a member. So again, there's lots of areas where if you look, we look forward and think, well, we should be doing this, we could do that, we could do that. But if you look back, there's been a huge change, and I'm sure it'll continue. And I will keep an eye on you on the Facebook page, drinking a glass of wine or something. So thank you very much for the opportunity. And once again, thank you for the presence I've had. I got to share with you, I told the group last night. So JJ asked what I wanted, so I said, I know this is public, but I did say I wanted wine, please. So 12 bottles of wine came last week when I was in Paris, and it was delivered to the house and put on the front step. My wife thought that I would want to open the box myself. So instead of taking a bottle out at a time, she picked up the box, and now she can't hardly walk. She injured her back. So she forgot all of her manual handling training. But that is a very nice present, and I've had a voucher as well, and I know I've got a card. So thank you very much. I'm very appreciative, and all the best for the future. I'll be watching. Thank you.
Thank you very much. Thank you, Paul, and thank you for not using the full 35 minutes. That is excellent.
I am finished.
Well, it's not all over yet, because the closed board has yet to come. I assume you're staying for closed board. Excellent, excellent, good. We can do it all over again. Okay, folks. So it's just come to 1 o'clock. Let's take the 45 minutes that we can afford to take. We were due to start at 2, but actually we can start earlier. So why don't we regroup here about 1:45 for the closed board? Give us 45 minutes to go across to Waitrose, which I know some do. Happy with that?